Jordan, why don't we go ahead and convene the meeting? So if you can read off the list of participants in the meeting to do a roll call, and then for the agenda, we're going to skip the first agenda item that Donna was going to go over, the P&T and DUR process overview, and we will just jump into atopic dermatitis.
Okay, so we'll get started here. We will now convene the P&T committee meeting. I'm Jordan Storhaug, the chair of the P&T committee. We do have two new members, Laura Bestie and John McKay. I might just give them an opportunity after we do the roll call to introduce themselves then. And first I'll just kind of run through the roll call. So after I call everybody's name, if you just be able to stay here so we can know who's here. So starting with the P&T committee members, first off is Virginia Bucola.
Good morning, I'm here.
Next is Diane Schwilke.
Good morning, I'm here.
Leah Marcotte.
Good morning, here.
Susan Flattabo. Kavita Chawala.
Here, good morning.
Laura Bestie.
Here.
Perfect. John McKay.
Good morning, I'm here.
Very good. And Alex Park and Michael Corsalis are absent today. For our healthcare authority members, Lita Tabascus.
Here.
Donna Sullivan.
Good morning, Jordan, I'm here.
Good. Ryan Pistoresi.
Here.
Marissa Tabell.
I'm here.
Luke Dearden.
Here.
Ryan Takatomo. Amy Irwin. Joey Zarati.
I'm here.
For the drug effectiveness review project presenters, Wesley Lindsay. Courtney Gamston.
And you know what? I haven't enabled all of their mics yet, so you could just run through their names, but don't wait for a response.
Okay.
Thanks.
Roz Kelly, Shannon Robolino, and Andrea Vintro. For Magellan Medicaid Administrative Presenter, we have Umang Patel.
I'm here.
Perfect. All right. For the Managed Care Organization representatives, Greg Samos of Molina Healthcare.
I also haven't enabled their mic, so you might just want to run through that list.
Heidi Goodrich of Molina Healthcare, Petra Edelolfer of United Healthcare, Umar Dumad of Community Health Plan of Washington, and Jeffrey Natividad of Community Health Plan of Washington. I want to come back and give the opportunity for two new committee members to introduce themselves. So first, Laura, would you be able to introduce yourself to the group?
Yes, good morning. I'm Laura Bestie. I'm a clinical pharmacist at Ellenmore Hospital, part of Multicare Health System, and I'm glad to be able to participate. Looking forward to it. Thank you.
Very good. Thank you and welcome. And then John, would you be able to introduce yourself to the group?
Sure. Good morning. My name is John McKay. I'm a pharmacy director with Native Project. We're an urban Indian healthcare center, CHC in Spokane, Washington. I spent most of my career in ambulatory care. Have worked with CHCs pretty extensively, and my most recent position is pharmacy director with Native Project.
Very good. Welcome to the group. So with that then, after a late start, we'll get going here. And our first topic will be
Jordan?
Yeah.
Sorry to interrupt you. This is Lita Vasquez. Let me just go over the meeting logistics really quick.
Absolutely. Thank you for interrupting me.
No problem. Okay, so I'm very sorry for the technical difficulties that we're having today. So the committee members should all be able to mute and unmute themselves. For the stakeholders, I'll unmute you when you're called on, and if you can use the raise hand function, if you're not on the pre-registered list, you'll have 3 minutes to speak. Presenters, please share your webcams when presenting, and the committee, you can share your webcams when you're deliberating on the motion. So for the stakeholders, the chair is first going to read through the pre-registered speakers, and I'll have to unmute you and then disable your mic. So please give me a minute if there's a pause. And you could also put questions in the chat function, but I'm going to ask that stakeholders do not continue entering in the chat during the motion deliberation. We cannot turn the chat off, so I don't want the committee to be distracted by stakeholders making comments when it's not the stakeholder comment period. And the meeting is being recorded, so please state your name every time you speak. This will be transcribed afterwards, and that makes it best for identifying who's speaking. And with that, I will turn it back to you, Jordan.
All right, perfect. Thank you so much. And so with that, I think we're really for atopic dermatitis, just turning it over to Wesley Lindsay from DUR.
Okay, let me share my screen. Okay, is Wesley unmuted?
All right, now it looks like it's given me the ability to unmute. Can everybody hear me?
Yes.
Can hear you.
Great. All right. Well, actually, I think maybe we've been trying to reach out to you if there could be the possibility of swapping the presentations today for atopic dermatitis and the biologics for non-asthma indications. My colleague, just because of the time changes, she has a little bit earlier deadline in the day, and so and I have a little bit more flexibility. So could there be any possibility of making that change?
Yes, we can do that. Let me change slides here.
I know everybody's really excited to hear about atopic dermatitis, but we're going to have to maybe just hold on for a little bit longer.
Okay, so biologic drugs for non-asthma.
Yes, please.
Okay. Okay, and Laura, can you check that Courtney Gamston is enabled to speak?
Yes, I'm
great.
able to speak. Hey.
Okay, let me share my screen again.
And thank you for making this change.
Oh, no problem.
To accommodate my schedule.
I'm sorry that we had difficulties today. My computer is being slow, so just a minute until it allows me to present here.
And just one question, how should I advance slides or ask you to advance slides?
You can just say next slide and I'll move it.
All right, thank you.
Okay, there we go.
All right, thank you. My name is Dr. Courtney Gamston, and on behalf of my team, I'm presenting this review of biologic drugs for non-asthma related indications. Next slide. And so this review will follow the same general format as previous DURP reviews. Next slide, please. I wanted to start off with a list of abbreviations that are included throughout this presentation. There are several included disease states, and for many, specific tools are utilized to assess the disease state. So this slide includes a collated list, but they are also spelled out on each of the slides on which they are included. Next slide. So the use of biologic drugs in asthma was analyzed in a previous DURP review, and the biologic drugs that are used to treat asthma may also be of benefit in non-asthma inflammatory conditions that are associated with diminished physical health and quality of life. These include chronic spontaneous urticaria, or CSU, eosinophilic granulomatosis with polyangiitis, or EGPA, hypereosinophilic syndrome, or HES, chronic rhinosinusitis, CRS, and chronic rhinosinusitis with nasal polyps. The currently available treatment options for each of these conditions do not fully alleviate symptoms in some patients and may result in undesirable adverse effects. Next slide. CSU is also known as chronic idiopathic urticaria and is caused by histamine release from mast cells that are activated by IgE, resulting in recurrent hives and/or wheals with or without angioedema. It is generally self-limiting but negatively impacts quality of life. Current treatments include antihistamines. EGPA was formerly known as Churg-Strauss syndrome and is a multisystem disease caused by activation of the IL-5 receptor that leads to proliferation of eosinophils. It is somewhat progressive and can affect one or more end organs. Without treatment, EGPA can be fatal. The current treatment for EGPA is systemic corticosteroids. HES is rare and characterized by continuous overproduction of eosinophils due to activation of the IL-5 receptor. Release of inflammatory mediators and infiltration cause organ damage. In some cases, this condition is also fatal. Systemic corticosteroids are the current treatment for this condition. Next slide. CRS is a common inflammatory condition that affects the paranasal sinuses and lining of the nasal passages. There are two subtypes, CRS with nasal polyps and CRS without nasal polyps. Nasal polyps are tumor-like swellings within the nasal mucosa. The current treatment for both subtypes of CRS is intranasal corticosteroids. Systemic corticosteroids are used for severe symptoms or exacerbations, and surgical removal of polyps is also employed, but recurrence is common. Next slide. The populations of interest vary by the biologic agent reviewed. For dupilumab, we focused on adults with inadequately controlled CRS with nasal polyps. For mepolizumab, we reviewed the literature for studies including adults with EGPA, participants 12 years of age and older with HES with no identifiable cause for at least 6 months, and adults with CRS with nasal polyps with an inadequate response to intranasal steroids. For omalizumab, the population of interest included participants aged 12 years and older with symptomatic CSU despite histamine therapy, and adults with nasal polyps with an inadequate response to intranasal steroids. Next slide. We reviewed 3 biologic medications. The table on this slide outlines the FDA-approved indications related to this review. So dupilumab was approved in March 2019 as add-on maintenance therapy for adults with inadequately controlled CRS with nasal polyps. Mepolizumab was approved for adults with EGPA in December of 2017. For individuals aged 12 years and older with HES without an identifiable non-hematologic cause for at least 6 months in September of 2020. And in July 2021, it was approved as add-on maintenance therapy for adults with CRS with nasal polyps that were inadequately controlled with intranasal steroids. Omalizumab was approved March 2014 for individuals aged 12 years and older with symptomatic CSU despite antihistamine therapy, and in November of 2020 as add-on maintenance therapy for adults with nasal polyps inadequately controlled with intranasal steroids. Slide. This table summarizes the activity of the reviewed medications and the disease states for which they were reviewed. All 3 are monoclonal antibodies. Dupilumab specifically targets IgG4, which inhibits IL-4 and IL-13, leading to inhibition of the release of pro-inflammatory mediators. This review assessed the evidence for use in CRS and CRS with nasal polyps. Mepolizumab is an IL-5 antagonist, which prevents the differentiation, recruitment, and activation and survival of eosinophils. We assess the evidence for use in CRS, CRS with nasal polyps, EGPA, and HES. Omalizumab is an anti-IgE antibody that inhibits IgE binding on immune cells, leading to a decrease in eosinophils and inflammatory mediators, including IL-4, IL-5, and IL-13. slide. Next slide. The criteria for this review included several comparators, though all identified eligible studies compared the biologic medications to placebo. We reviewed only randomized controlled trials. Next slide. The outcomes of interest included symptom control, quality of life, occurrence of severe exacerbations, hospital admissions, and a list of condition-specific outcomes as listed on this slide. We also reviewed harm outcomes, including mortality, adverse events, and serious adverse events. Next slide. The key questions for this review included examination of the effectiveness of the included biologic drugs, and the harms associated with the use of these medications for the included indications, and the characteristics of ongoing studies for the use of these biologic agents for the treatment of the included disease states. Next slide. So now we're going to shift gears and discuss the methods for this review. Next slide. The reviewed evidence sources included Medline, the Cochrane Library, and Google Scholar. We also reviewed ongoing studies through clinicaltrials.gov, the FDA, and utilizing the International Standard Randomized Controlled Number. Next slide. And this review was completed in accordance with the methods of the previous DURP reviews. Next slide. The risk of bias was assessed as low, moderate, or high based on reporting of methods, potential biases, and conflicts of interests. In order to receive a rating of low, the methods must have been clearly reported, potential biases must have been mitigated, and conflicts of interest must have been absent or insignificant. Next slide. We assess the certainty of evidence using the grade criteria for numerous outcomes related to the use of biologic medications, and they are listed across the top. Next slide. All right, now we'll move into findings. Next slide. We identified a total of 88 studies and excluded 51 of these studies. 37 full text documents were assessed for eligibility, 10 of which were excluded from the analysis due to not being within the scope of this review. We evaluated 9 new documents and 18 documents that were carried forward from the DURP review of biologic medications in asthma. Next slide. If y'all go back, yes, thank you. We reviewed a total of 10 publications for CSU, all of which focused on the use of omalizumab. This included 8 randomized controlled trials, 1 additional report of study data, and 1 subgroup analysis. We reviewed 2 publications for EGPA, both of which examined the use of mepolizumab. This included 1 randomized controlled trial and 1 post hoc analysis. There were 3 included publications for HES, all of which examined mepolizumab. This included 2 randomized controlled trials and 1 subgroup analysis. Next slide. For CRS and CRS with nasal polyps, 12 publications were included in the review. All 3 biologics of interest were reviewed within these 12 publications. For omalizumab, there were 3 randomized controlled trials. There were 2 randomized controlled trials for dupilumab, 2 additional reports of study data, and 2 subgroup analyses also included. And for mepolizumab, we reviewed 3 randomized controlled trials. Next slide. For ease of understanding, we grouped the findings by disease state instead of by medication. Next slide. There were several instruments used to assess CSU. They are listed here and you will see them throughout the next several slides. They included the Urticaria Activity Score, or UAS, and weekly urticaria activity score, for which a higher score indicates increased disease activity. The weekly itch severity score, for which a higher score also indicates an increased severity. The dermatology life quality index and chronic urticaria quality of life are also included, for which a lower score indicates a better quality of life. And the angioedema activity score, a higher score there indicates increased disease state activity. Next slide. I will provide a brief summary for each of the slides containing study-specific information. In each of these slides, the first column provides the publication information. All of the included trials were randomized controlled trials, which can be seen in the second column, along with the number of participants in each trial. Their intervention and primary outcomes are listed in columns 3 and 4, respectively. Column 5 includes the study duration, and the risk of bias appears in column 6. For the majority of the included studies, the risk of bias was rated as moderate. This slide and the next 2 slides contain information about the 10 included studies for CSU. Every study evaluated the use of omalizumab. The 3 studies listed here included 49 to 336 participants and evaluated omalizumab 75 to 375 milligrams given subcutaneously every 2 to 4 weeks depending on dose and range from 27 to 40 weeks in duration. Primary outcomes included change in the weekly urticaria activity score from baseline, change in the itch severity score from baseline, and frequency and severity of adverse effects. Next slide. The next 3 studies and 1 report of additional study data enrolled 30 to 319 participants and evaluated omalizumab 75 to 300 milligrams given every 4 weeks. These studies spanned 20 to 40 weeks and evaluated the change in itch severity score, change in the chronic urticaria quality of life questionnaire, or change in the concentration of the high affinity IgE receptor or IgE positive skin cells from baseline. Next slide. The 2 studies and 1 subgroup analysis included on this slide included over 100 participants each and compared 150 to 300 milligrams of subcutaneous omalizumab every 4 weeks to placebo. Study duration was 26 to 40 weeks. One of the studies evaluated the change from baseline in the weekly itch severity score, while the other examined the percentage of participants with clinical worsening as evidenced by as measured by an elevated weekly urticaria activity score for at least 2 consecutive weeks. Next slide. The first outcome of interest seen in the top half of the slide was the change in that weekly urticaria activity score. The minimally clinically important difference, or MCID, is 9.5 to 10.5 based on the literature. 7 randomized controlled trials for the use of omalizumab included 1,500 participants were reviewed for this outcome. The evidence was graded as moderate, and omalizumab was found to be superior to placebo. At 300 milligrams, the mean treatment difference ranged from negative 8.6 to 12.8 versus placebo. At 150 milligrams, the mean treatment difference ranged from negative 4.9 to negative 6.5 versus placebo. The second outcome of interest was the change in the weekly itch severity score. The MCID for this tool was not found within the literature. We evaluated 4 randomized controlled trials with omalizumab as the subject medication that included a total of 860 participants. The evidence was graded as moderate, and omalizumab was found to be superior to placebo. The 300 milligram dose was associated with a mean treatment difference of negative 3.7 to negative 5.8 versus placebo, and the 150 milligram dose was associated with a mean treatment difference of negative 2.3 to negative 3.0 versus placebo. The authors also tested a 75 milligram dose, but this dose rarely produced a statistically significant difference when compared with placebo. Next slide. The next outcome of interest was change in the Dermatology Life Quality Index, which has an MCID of 4. This outcome was evaluated in 7 randomized controlled trials of omalizumab and included 1,132 participants. The evidence was graded as moderate, and omalizumab was found to be superior to placebo. At a dose of 300 milligrams, the mean treatment difference was negative 3.1 to negative 4.7 versus placebo. At 150 milligrams, the mean treatment difference was negative 1.9 to negative 2.5 versus placebo. For adverse events, we reviewed 7 randomized controlled trials for their use of omalizumab, which included 1,366 participants. The evidence was graded as low. The results suggested a similar occurrence of adverse effects for participants in both the omalizumab and placebo groups. Next slide. So now we'll cover the evidence regarding EGPA. Next slide. There were only 2 identified publications that examined the use of one of the biologic medications of interest for EGPA. There was 1 trial and 1 post hoc analysis of trial data. There were 136 participants, and the use of mepolizumab 300 milligrams administered subcutaneously every 4 weeks was compared with a matched placebo. The primary outcomes included total accrued weeks of remission and the proportion of participants with remission at both weeks 36 and 48, and the study spanned 60 weeks. Next slide. For the outcome of remission, 1 randomized controlled trial examining the use of mepolizumab included 136 participants, as mentioned on the slide previously, and the evidence was graded as low. The evidence demonstrated increased accrued time in remission compared to placebo. 28% of participants in the mepolizumab group compared with 3% of participants in the placebo group achieved at least 24 weeks of accrued remission, resulting in an odds ratio of 5.91. Next slide. The same study evaluated the outcome of relapse. The evidence was assessed as low and demonstrated that delayed occurrence of the first relapse in participants in the mepolizumab group compared with placebo. 56% of participants in the mepolizumab group compared with 82% of participants in the placebo group experienced a relapse during the trial period. For the outcome of adverse events within this same study, the evidence was graded as moderate, and no statistical difference in adverse effects was found between the mepolizumab and placebo groups. Next slide. All right, and now we will take a look at HES. Next slide. For HES, 2 trials were identified, as well as 1 subgroup analysis. The interventions consisted of either mepolizumab 300 milligrams administered subcutaneously or a 750 milligram infusion, each given every 4 weeks for either 32 or 36 weeks. The primary outcomes included the reduction in daily prednisone use or the proportion of participants with a flare occurrence within the study period. Next slide. For the outcome of dose reduction for systemic corticosteroids for mepolizumab in 1 randomized controlled trial, including 136 participants, the evidence was graded as moderate, and it was found that mepolizumab significantly reduced the use of prednisone dose during the treatment period when compared with placebo at a rate of 84% in the mepolizumab group and 43% in the placebo group, with a hazard ratio of 2.90. Next slide. For the outcome of time to first flare occurrence in that same population, the evidence was graded as moderate, and it was found that mepolizumab occurrence of flares in the mepolizumab group, the occurrence of flares was 50% lower than with placebo. With regard to adverse events, the evidence was rated as low, and statistical analysis was not performed on treatment-related adverse effects, and generally the adverse effect occurrence was similar between the treatment and placebo groups. Next slide. So we'll move into our last disease state, and this is CRS and CRS with nasal polyps. Next slide. For CRS and CRS with nasal polyps, there are several assessments and questionnaires utilized to assess disease state status and control, symptomology, and quality of life. The nasal polyp score and total polyp score assess the occurrence and obstruction of nasal polyps, with a higher score indicating worse disease state status. The nasal congestion score is a measure of symptomology, with a higher score indicating worse disease state status. And the short form health questionnaire, asthma quality of life questionnaire, and sinonasal outcomes tests all assess quality of life, though higher scores for the SF36 and sub-Q indicate a better quality of life, and a lower score for the SNOT-20 and SNOT-22 indicate better disease control and quality of life. For the University of Pennsylvania Smell Identification Test, a higher score indicates a better sense of smell, and the Lund-Mackay CT score assesses opacification of the sinuses, with a higher score indicating higher opacification and worse disease state or control or severity. Next slide. For the studies examining the use of biologics in CRS, we organized the studies by individual agent. So on this first slide, the 3 listed studies included 14 to 265 participants, and the intervention consisted of omalizumab based on body weight and serum IgE that ranged from 75 to 600 milligrams and was administered sub-Q every 2 to 4 weeks depending on the dose. These studies spanned 16 weeks to 6 months, and the primary outcomes included change from baseline in nasal polyp score, total polyp score, nasal congestion score, or sinus inflammation. Next slide. There were 2 studies identified that evaluated the use of dupilumab as well as 1 post hoc analysis, 1 subgroup analysis, and 2 additional reports of study data. There were 60 and 1,902 participants in the 2 trials. They evaluated dupilumab 200 milligrams or 300 milligrams, and one of the trials gave a loading dose. The primary outcomes included annualized severe asthma exacerbation rate, because this was a post hoc analysis of an asthma trial, and change from baseline in pre and post bronchodilator FEV1. For the second trial and the 2 additional data reports, the primary outcome was change in bilateral nasal polyp score from baseline to study end at 16 weeks. And the other trial lasted for 52 weeks. Next slide. For the trial and subgroup analysis listed on this slide, there were 724 participants and then a subgroup of 49 participants that were evaluated. The intervention included dupilumab 300 milligrams every 2 weeks for 52 weeks, or every 2 weeks for 24 weeks, followed by every 4 weeks for 28 weeks. Primary outcomes included change in NPS and change in NCS at 24 weeks and change in the Lund-Mackay CT score at 24 weeks. The studies lasted for 48 weeks and 64 weeks. Next slide. There were 3 studies that examined the impact of mepolizumab on CRS and CRS with nasal polyps. They included 30 to 407 participants and investigated the use of 100 milligrams of mepolizumab administered sub-Q or 750 milligrams via IV infusion every 4 weeks. Primary outcomes included change from baseline in that total polyp score, change in the nasal obstruction visual analog scale or VAS during weeks 49 to 52, and the number of patients or participants that were no longer candidates for nasal polyp surgery based on NPS and the VAS. These studies lasted for 25 to 52 weeks. Next slide. The evidence for change from baseline in the nasal polyp score for omalizumab comes from the 2 randomized controlled trials that included 303 participants. Actually, it looks like, can you go back 1 slide? I'm a little bit out of order here. All right, go down 1 slide. All right, so when we were looking at the change from baseline in that FEV1, we're actually looking at dupilumab. 3 included randomized controlled trials that covered 2,686 participants. The evidence was graded as moderate, and it was found that dupilumab inconsistently improved that FEV1 from baseline compared with placebo. That mean change range was from 0.12 to 0.34 liters. With regard to change from baseline in that total polyp score, mepolizumab in 3 randomized controlled trials, including 551 participants, demonstrated that more participants achieved a significant reduction in that total polyp score compared with placebo. The treatment difference range was from -0.9 to -1.3, and that evidence was graded as moderate. Next slide. The evidence for change from baseline in the nasal polyp score for omalizumab comes from 2 trials that included 303 individuals. The evidence was rated as moderate and demonstrated that omalizumab significantly improved that nasal polyp score compared with placebo. That mean treatment difference range was -0.59 to -1.14, and it was found that there was a 1 point or greater improvement in that nasal polyp score in 56.3% of the omalizumab treated group compared with 28.7% of individuals in the or participants in the placebo group. For the change from baseline in the nasal congestion score, this was evaluated in 1 randomized controlled trial for omalizumab in encapsulated 265 participants. The evidence was graded as moderate, and it was found that omalizumab significantly improved that nasal congestion score compared with placebo, with a mean treatment difference range of -0.5 to -0.55. Next slide. So on this slide, we're actually looking at the same outcomes, but for the use of dupilumab. So for dupilumab, in 2 randomized controlled trials and 844 participants, the evidence was graded as moderate, and it was found that dupilumab significantly improved that nasal polyp score compared with placebo. With regard to change from baseline in that nasal congestion score, there was 1 included randomized controlled trial for dupilumab, which encompassed 784 participants. The evidence was once again graded as moderate, and it was found that dupilumab significantly improved that nasal congestion score compared with placebo. Next slide. For the reduction in the SNOT score, there were 2 different versions of the SNOT score that appeared in these trials, the SNOT 20 or the SNOT 22. The MCID was 8.9. For omalizumab in 2 randomized controlled trials and 279 participants, moderate grade rating of evidence found that omalizumab use was associated with a significant SNOT score reduction compared with placebo. The SNOT 22 treatment difference was -21.59 to -24.7 versus placebo. And for SNOT 20, that mean change in the median score was -1.05 versus -0.2 versus placebo. For dupilumab, there were 3 randomized controlled trials that assessed this outcome, which included 2,686 individuals. Again, the evidence was rated as moderate, and dupilumab was found to significantly reduce the SNOT score compared with placebo. At 16 weeks, that treatment difference was -18.1 versus placebo. At 24 weeks, it was -10.32 to -21.12 versus placebo. And at 52 weeks, it was -11.5 to -20.96 versus placebo. Next slide. And for mepolizumab, with regard to the same SNOT 20, SNOT 22 outcome, in 1 randomized controlled trial and 414 participants, it was found that mepolizumab use was associated with a significant score reduction compared with placebo. This evidence was graded as high, and that treatment effect was -16.49 versus placebo. Next slide. With regard to the SF36, I wanted to start by taking a look at the different domains. So the domains are listed here, and each has their own MCID. So we have physical functioning, role limitations with regard to physical health, role limitations with regard to emotional area, vitality, emotional well-being, social functioning, pain, and general health. Next slide, please. And it's important to break it down by domain because there were differences in some domains, but not in others. So with regard to improvement in that SF36, for omalizumab in 2 randomized controlled trials and 38 individuals, omalizumab improved specific domain scores compared with placebo, and those included the physical health domain, which improved in 1 study, and the vitality domain, which improved in 1 study. For dupilumab in 1 randomized controlled trial with 60 participants, dupilumab improved specific domains as well. It was found that there was significant improvement in 5 domains: general health, physical functioning, role physical, social functioning, and vitality, versus no improvement in the placebo group. Next slide. There are also multiple domains for the Asthma Quality of Life Questionnaire, which includes symptoms, activity limitation, emotional function, and environmental stimuli. Next slide. For the AQ-LQ, the MCID is 0.5. For omalizumab in 2 trials, including 289 participants, the evidence, once again, was rated as moderate, and it was found that omalizumab significantly improved the AQ-LQ compared to with placebo, specifically within the domains of activity limitations, symptoms, and emotional function. For dupilumab in the 1 trial, including 1,902 individuals, dupilumab significantly improved that AQ-LQ score compared with placebo at 52 weeks. And you can see the difference in the mean differences at the 2 different doses that were utilized, the 200 and the 300 milligram doses. Next slide. With regard to adverse events for omalizumab in the 2 included trials and 303 participants, we found that there were mild adverse effects that were common, but they occurred at a similar rate compared with placebo, and common cold was the only adverse effect to occur more often in the omalizumab group. For dupilumab in 2 trials and 844 participants, mild adverse effects were common, but there were no differences found between the groups. Next slide. And for mepolizumab in 2 trials and 437 participants, mild adverse effects were common, and there were no differences found between groups. Next slide. And for now, we're going to take a moment to talk about the ongoing studies. Next slide. So there are currently 2 CSU studies that are focused on dupilumab with sample sizes of 72 and 234. They have a shared outcome of that weekly urticaria activity score. There are 3 ongoing studies for CRS without nasal polyps. And this is interesting because there were not previously any studies of including participants with CRS without nasal polyps that were specifically designated as such. The sample size ranges from 30 to 240, and the shared outcomes include that SNOT-22 and the University of Pittsburgh smell identification test. Next slide. There are 2 trials currently ongoing for CRS with nasal polyps. One is looking at dupilumab with a sample size of 36, and they are also looking at that SNOT-22, but also use of systemic corticosteroids and the severity of rhinosinusitis. And there is 1 trial looking at mepolizumab. The sample size is 160, and those key outcomes include the total endoscopic nasal polyp score, the nasal obstruction visual analog scale, and that SNOT-22. Next slide. Next slide. We identified several randomized controlled trials that evaluated omalizumab, dupilumab, and mepolizumab for the indications of interest. There were no available head-to-head trials. Instead, all of the identified trials compared the subject medication to placebo. The certainty of evidence for relevant outcomes was generally rated as moderate, and there were no new concerns noted with regard to adverse effects. For CSU specifically, we found that omalizumab 300 milligrams administered every 4 weeks consistently achieved significant differences in the assessed outcomes. Future studies assessing increased doses may be beneficial. Next slide. For eGPA, the research was scarce, resulting in a low certainty of evidence for efficacy outcomes. The data suggests that mepolizumab 300 milligrams administered every 4 weeks could be utilized to decrease relapse and sustained remission. Given the progressive nature of this condition and the potential for severe outcomes up to and including death, this is actually a valuable finding. Additional evaluations of symptom relief, use of systemic corticosteroids, and quality of life would be beneficial. For HES, the administration of mepolizumab resulted in a reduction in systemic steroid use and reduced flare occurrence. Similar to eGPA, this condition can result in serious health outcomes, so the finding that mepolizumab can decrease flares is significant. Next slide. All 3 of the biologics of interest demonstrated efficacy in improving both symptoms and quality of life in participants with CRS. Dupilumab demonstrated inconsistent improvement in the FEV1, though there were few studies assessing this endpoint, and there were no studies that assessed this endpoint as the primary outcome. The majority of the identified studies included only participants with CRS with nasal polyps, and none of the identified studies assessed CRS without nasal polyps specifically. In CRS with nasal polyps, all 3 biologics were shown to decrease nasal polyp burden, as evidenced by the nasal polyp score as well as the nasal congestion score. Next slide. So this concludes this presentation, and I just want to thank you for your time today, and I would be happy to answer any questions that you have about this review.
Thank you, Courtney. Just we can double check. I'm not seeing any questions. Thank you so much. With that, then we'll move on to our stakeholder input. For each of these, there'll be 3 minutes available for comments. And our first one is Margaret Ullman of AbbVie.
Hi, can you hear me?
We can hear you.
I'm on the atopic derm
presentation
instead of this one.
Catch me up here. I lost myself. So
that's
yeah.
Okay. I'll talk to you soon. Thanks.
We'll see you after that one. So my mistake there. Actually, our first and only one here is Long Nguyen of GlaxoSmithKline.
Okay, this is, oh, I'm sorry. Go ahead.
Yes, good morning, everybody. And my name is Long Nguyen. I am a health outcome liaison from medical affairs at GlaxoSmithKline, providing comments on Nucala. And I would like to extend my appreciation for a wonderful evidence demonstrating from Dr. Gamston based on the DUR report, very accurate. And thank you so much for your work on that. I just want to make a couple of comments that to remind the committees that in addition to severe asthma, Nucala is the only biologics indicated to treat rare eosinophilic driven disease such as EGPA or, as you already know, Church-Strauss syndrome, as well as HES. And as Dr. Gamston alluded to, these severe diseases does have a very negative consequences in patients who are diagnosed with them. It could result in death, but also it results in significant changes and detrimental changes in quality of life. I just want to remind the committees that in our clinical trials in patients diagnosed with EGPA, our trials show that adding Nucala to standard therapy of daily OCS and immunosuppressive. So these patients were not on placebo. They were on standard of care. And the Nucala and the patients receiving Nucala sustained the duration of remission and reduce the daily average of doses of oral corticosteroid needs compared to those who receive standard of care. And similarly, in the hypereosinophilic trial, or HES, Nucala statistically significantly reduced the annualized rate of flares by up to 66% in patients diagnosed with HES. So since Nucala is the only biologic indicated for these two rare diseases and is currently not preferred on the PDL, I asked the committee to vote to have Nucala available as a preferred biologic for patients diagnosed with EGPA and HES on the Washington PDL drug list. And so thank you very much. That will conclude my comment for today, and I will be happy to take any questions. You're on mute.
Jordan, you're on mute.
Thank you. So thank you so much for that presentation. I just wanted to give an opportunity for people as well, if anybody wants to raise their hand to speak. And if not, then we can
this is
look at the
Lita.
motion.
I don't see any hands raised.
So let's go ahead and take a look at the motion.
Give me 1 second to get that up.
Kavita Chawla here. So Lita or Donna, just for clarification, is our motion going to be the motion as listed there, except just the 3 drugs that were reviewed today? Not including the benralizumab and the reslizumab?
No, those are, it would include, this is Donna, it would include all of the drugs. That was just an add-on from the previous reports.
Okay.
Except this is Lita Vasquez. Ryan Pastoresi, maybe you can talk to us a little bit. So these are biologics for non-asthma conditions. So the end of this would have to be changed.
Right, and I guess, maybe what we can do is, carry these drugs forward so that way they're not lost, and just kind of, focus on the details for what was reviewed in today's report and for those conditions. So, this was for the non-asthma conditions, but, we'll still be able to carry this forward since these are the biologic drugs for asthma.
So this is Lita. Maybe I'll just start this off up here for non-asthma. And do I include chronic spontaneous urticaria or leave that off?
I think you can just, this is Donna, I believe if we just delete asthma from the motion, did we cover those other indications, the chronic spontaneous urticaria and other indications?
Yeah, we might want to say, they're FDA approved indications.
Yeah, because we looked at the rhinosinusitis, urticaria, eosinophilic granulomatosis, hypereosinophilic syndrome, and these polyps.
Right. Yeah. Instead of listing them all, just, for the treatment of their FDA approved indications for non-asthma. Not sure what the right language would be.
Why don't you say their FDA indications excluding asthma?
Yeah, okay, that works.
And Kavita,
Assuming.
this is Donna again. Going back to what you said, I forgot that this was the non-asthma biologics, and then we were doing it differently. So yes, we would only be speaking to the 3 drugs that were reviewed today. The other drugs will be reviewed for their asthma indications separately.
This is Susan Flattabo. After considering the evidence of safety, efficacy, and special populations for the treatment of chronic spontaneous urticaria and FDA-approved indications excluding asthma, I move that dupilumab, mepolizumab, omalizumab are safe and efficacious for the treatment of their approved indications. Dupilumab, mepolizumab, and omalizumab can be subject to therapeutic interchange in the Washington PDL for chronic spontaneous urticaria and their FDA-approved indications excluding asthma. Is that right?
Yeah, Lita was going not as fast. I think, this is Donna, as a friendly amendment, I think we could delete spontaneous urticaria and just say their FDA approved indications excluding asthma. It'll be a little bit less awkward.
Does that make sense up here too for the treatment
Yes.
of their FDA approved? Okay.
This is Kavita Chawla. I second the motion.
All right, then, all in favor, please say aye.
Aye. Aye.
Aye.
Any opposed? All right, looks like we can pass unanimously.
This is Laura Bestie. I just had a quick question. Since the previous recommendation from 2021 refers to chronic spontaneous urticaria, does this one automatically replace that because it lists it separately? So until the asthma one is reviewed again, it would override it?
This is Ryan. That was the motion from, 2021 before this report, kind of split off and was focusing on all these other indications. So I wouldn't necessarily say that we would need to re-review the asthma ones to update that. I think the previous drugs that were reviewed and have that motion would still apply going forward. It's just that this new one that we reviewed and approved just now would be able to apply, going forward, on top of that. So it would be in addition to the chronic spontaneous urticaria that was mentioned in the last motion.
Okay.
Any other questions on that topic? Not our schedule is kind of modified there, but I'm hoping we're able to kind of try to do atopic dermatitis now and get that report from Wesley Lindsay.
I've been warming up on the sidelines over here, so I'm ready to get in the game whenever you'd like, Coach.
Thank you. This is Lita. I'm opening up the presentation now.
Do you prefer camera on, camera off for the presenter?
Camera on would be great.
Oh, good. I put a tie on today, so that hasn't happened in some time, probably.
Sorry, my computer's taking a minute here to open this.
No, this is fine. And while we're transitioning into this, I'm not sure if my affiliation is completely clear. I'm actually presenting from Auburn University today. So I understand in Spokane, you also have a basketball team, Gorgonzola or something like that, that seems to think they're pretty good. But we're coming. We're getting better at this. Yeah, is that not what it's called? Did I get the name right?
I don't know, Jordan.
Something like that. We'll
Oh,
practice later, maybe.
Okay. I'll say we're new to this good at basketball thing, so our trash talk is probably, not as good as it needs to be. That it's still a work in progress. So
All right.
You'll have to help us out on that.
Sounds very good. All right. I think we're all set. So you can start whenever you're ready.
All right. Thank you very much. I really am glad to join you today. I do always enjoy getting out and getting to present to some new folks. And it's my pleasure today to talk about atopic dermatitis. So next slide, please. So this has been an area that's had a lot of activity, and I know that you know that because this is, why we're talking about it. There have been quite a few new drugs, a lot of new developments in this particular therapeutic area. For our overview, we follow the typical DUR process for a systematic review, and we'll have all the traditional components that you've come to expect as part of a DUR review. And we actually had a previous systematic review on this topic done, which we'll talk about in just a moment. So next slide, please. A little bit of background and context. Atopic dermatitis, something that we're probably all on the call familiar with. It's a chronic inflammatory skin disease, can cause intense itching and recurrent lesions that relapse and remit. It can be caused by environmental, genetic, and immunologic components. Usually it shows up or presents by age 5, but it still can manifest later and present later in life. Adults and children report with atopic dermatitis negatively impacting their self-esteem, reporting limiting social interactions. Also, they talk about they avoid discussing their condition, and it also has a strong impact on their clothing choices that they typically want to cover up and may not be able to dress in the manner that they would like to do. The initial treatments typically start with avoiding triggers if we have some known trigger that causes that. If we're able to, or that is not able to control disease, we move along to something like using moisturizers, potentially corticosteroids, and also incorporating phototherapy if needed. So next slide. As I mentioned, this is actually an update to a previous DURP systematic review from 2017. And in the previous report from 2017, we identified 43 randomized controlled trials from the listed interventions. What you'll find, though, is a preview of coming attractions for a little bit later in the report. There wasn't a whole lot that we were able to carry forward from this 2017 report to today. And a lot of that was because the 2017 report focused on mild to moderate atopic dermatitis, whereas you'll see in just a moment when we get to the PICOs for this report, we focused on moderate to severe. We also, the comparators that were assessed in the previous report in 2017, that was a little bit different than the comparator structure for what we wanted to evaluate for this. So even though that was a very good report, it is a little bit different what we're going to be talking about today, just in terms of severity and the agents that are involved. So next slide, please. The populations that we're going to look at adults and children, so essentially all ages with moderate to severe atopic dermatitis. Next slide, please. As I mentioned, this is a therapeutic area with a lot of activity. So what you're going to see on this particular slide, these are the FDA approved agents, but we'll classify these as maybe the older FDA approved agents. So these are all the agents that were approved in 2017 prior. And a lot of these names are going to look familiar to you. You can see that we have quite a few different drug classes, from immunosuppressants to calcineurin inhibitors, et cetera. And so these are the older agents that we're going to use. I'm also going to just go ahead and throw a disclaimer out there. Talking about pimecrolimus and tacrolimus, there's a lot of confidence in people to how they say these, but nobody is really exactly sure. So how I pronounce them later on in the presentation, it may just be whatever the moment strikes me. So that's part of the fun, is being able to pronounce these different ways. And hey, confidence over competence sometimes when it comes to pronouncing drug names. So just a little bit of a warning there. Plus, if I pronounce it differently every time, I never have to remember, how did I say it last time? And try to be consistent. So I'll just go ahead and throw that out there for everybody's benefit. Our next slide, please. So this is the newer set of agents. So these have all been approved from September 2021 to present. As you can see, 2 of those were actually approved in January of 2022. So we have 3 Janus kinase inhibitors and the 1 interleukin 13 antagonist that have all, again, been recently approved for atopic dermatitis. And actually, when we started the project, all 4 of these were still considered pipeline agents, but again, now have all made it to market and been FDA approved. Next slide, please. So this is the final list of agents that we'll be talking about. These currently are still in the pipeline working towards FDA approval for atopic dermatitis. So you can see our baricitinib, lebrikizumab, nemolizumab, and tradipitant. So those are the 4 agents currently still in pipeline status, and we'll again be talking about those a little bit later in the presentation. So next slide, please. The comparators. So we want to look at any of the other included interventions. So anything that we can evaluate head to head. We wanted to evaluate with or against topical corticosteroids. And also for the pipeline therapies, wanted to look at standard of care or placebo. Next slide, please. For the outcomes, we wanted to look at a number of efficacy and effectiveness outcomes. These are the ones that we're going to focus on for our presentation today. The Investigator Global Assessment, or IGA, the Eczema Area and Severity Index, or EASI, the Scoring Atopic Dermatitis, which is our SCORAD, and then we had 2 different quality of life assessments, the Dermatologic Life Quality Index, which is used in adults, and the Children's Dermatology Life Quality Index, which is used obviously in children. And unfortunately, I don't have any great acronyms like Dr. Gamston had in the previous presentation, where one of her assessment tools is called the SNOT. Unfortunately, mine are just a little bit less colorful than that. So for our next slide, we'll talk about our harm outcomes and traditional harm outcomes, overall adverse events, serious adverse events, and then withdrawal of treatment due to adverse events. For our study designs, we focused on randomized controlled trials for this specific review. All right, next slide, please. Our key questions would be those that you would traditionally expect with a DURP systematic review. We want to look at the comparative efficacy of the FDA-approved interventions, as well as the comparative efficacy of the pipeline therapies. Look at the comparative harms of those, and then look at the characteristics of ongoing studies for the interventions that are included in this review. Next slide, please. So to get into our methods, next slide. We followed the traditional DURP systematic review process. We evaluated the typical DURP evidence sources such as Medline, Cochrane Library, Google Scholar, etc., and the traditional ongoing studies sources such as clinical trials and the FDA. And then we also used the resources that were explored in the previous report from 2017, and we evaluated the randomized controlled trials and meta-analyses, as well as there were also some additional systematic reviews, and we evaluated the bibliographies, etc., for any additional and relevant resources or studies for this project. Our next slide. Again, following our traditional DURP stepwise methods, we searched our evidence sources, performed our distiller screening and evaluation of those with the risk of bias assessments, used our GRADE approach for certainty of evidence, and then searched the resources mentioned for our ongoing studies. Next slide, please. So this is the, again, typical DURP risk of bias assessment. The levels and the descriptions are the same. The color codings have changed just a little bit. So in Courtney's presentation previously, you saw we sort of had the red, yellow, green color scheme, and now we've changed that a little bit. So you can see that low is represented as this sort of light blue color, moderate is sort of the purple color, and then those that had a high risk of bias are indicated with red. Next slide, please. Similarly, the color system for the grade certainties of evidence has been adjusted a little bit. Again, the descriptions are the same. And for this particular report, I mentioned earlier the clinical assessments that we used for our grade rating, which is the SCORAD, EASI, IGA, and the quality of life assessments, as well as the adverse events. So as you can see, again, the high, for those that have a high certainty of evidence, will be indicated with this light blue color. Outcomes associated with a moderate color or a moderate level of evidence associated with this purple color. Low confidence or certainty of evidence will be this orange color, and then a very low will be this more reddish, bright reddish color. Next slide, please. So what we're all here for, let's dive into the findings for our atopic dermatitis medications. So next slide, please. These are just very brief descriptions. I'm not going to go through all of this with you, but just wanted to provide a brief overview of the outcomes that are being used for the grade assessment for this review. So you can see, again, just a brief description here of the life quality indices, the eczema area and severity index, the IGA, and the SCORAD. So you can see that they all have slightly different scales and levels from 0 to 30, 0 to 72, 0 to 4, etc. And one thing that I do want to just kind of take away from this is for all of these assessments, higher scores indicate more serious or more disease activity. So as we talk a little bit later in the slides, for all of these, we're looking to lower the scores for all of these assessments. And I know that's not always the case for every therapeutic area, but for this one, high scores commonly indicate worse disease, low scores, improvement. So our next slide, please. So here's our Prisma diagram to give you an indication of the flow of information through our project. And if you just want to hit the next advance, I think it will highlight the bottom portion of our Prisma diagram. There you go. So you can see we started with 174 documents through our searches and 66 in the original report that included randomized controlled trials and other resources. And eventually we worked our way down to 47 original publications for this review and 6 which we carried forward from the previous 2017 DURP review. So a total of 53 publications. And as you can see on the next slide, we had 47 original publications, as I just mentioned, and 40 of those were original studies. You can see the list below there. These are the sort of tally of studies that we had for all of the FDA-approved therapies. So you can see them listed alphabetically. You can see that cyclosporin had the largest number of studies. And one thing that I'll also point out with the sub-bullets to cyclosporin, it also had several head-to-head comparisons, which we'll talk about in just a moment as well with other active therapies for atopic dermatitis. As noted in the bottom for crisaborole, dupilumab, and tacrolimus, we had no new studies for this particular review that we were able to find that fit within the scope of our project. Next slide, please. So this is what we found for the FDA pipeline therapies. So you can see for baricitinib, 6 studies, lebrikizumab 2, nemolizumab 3, and actually for tradipitant, we didn't find any studies published at the time that we initiated this project for atopic dermatitis. So there are quite a few that are going on and in process, but none that have been published at at project initiation. Next slide, please. All right, so here's kind of the star of the show, this and the next 3 slides. So what we have for this particular slide, these are those older agents that we have. So the azathioprine, cyclosporin, omalizumab, pimecrolimus. And so these are the 2017 and prior approved FDA or FDA approved products for atopic dermatitis. So on the left, you can see the comparator that is being evaluated. Across the top, you can see the assessment tool or the graded or the assessment that we provided a grade outcome for. And then in the body of the table, you can see the assessment of the grade certainty of evidence that was assigned to each of these particular therapies and to the attendant outcomes with it. So generalizing as we look through the table, you can see that for azathioprine, many of the outcomes that were assessed in this case were assessed as low. For cyclosporin, virtually all of the outcomes that we graded for this particular therapy were all assessed as very low. For omalizumab, again, it's that orange color, and you can see that those are assessed as low. And with pimecrolimus, you can see that we had moderate certainty of evidence with those, or with that particular intervention. So just kind of generally speaking, in the big takeaway, you can see that for those older therapies, the certainty of evidence isn't particularly great for those treatments. So if we can move to the next slide, please. So this is the same information, but this is for the batch of newer agents, so the ones that have been approved in the previous 6 months. Once again, you can see on the left-hand side the agent and the comparator that is being evaluated. Across the top is the assessment that's being graded, and within the body of the table, you can see the grade and actual certainty of evidence that was assigned to that particular comparison and outcome. So you can see with abrocitinib versus placebo, for the certainty of evidence, we evaluated that as being high. For abrocitinib and dupilumab and placebo, a mostly moderate level of evidence there. Ruxolitinib had a high level of evidence. Tralokinumab, a little bit different. We had moderate to low. We saw some inconsistencies, and we'll talk about some of those specifics study to study, which led to our sort of downgrading of evidence for this particular agent. And for upadacitinib, generally having high certainty of evidence for these studies. If we can move to our next slide. So this is the certainty of evidence that we assessed for the pipeline therapies. So you can see for baricitinib, lebrikizumab, and nemolizumab. For baricitinib, we generally assessed it as having a high certainty of evidence. For lebrikizumab and nemolizumab, we see a bit more inconsistency. And as you'll see a little bit later on, and we'll again describe in a little more detail, then what we saw was inconsistent outcomes and maybe even some overlap in indirect comparisons of studies between placebo and these active treatments. And so again, maybe not as a consistent change as you might see for some of the other therapies. So those are some of the, again, sort of big picture takeaways and visuals for this. And if we can move on to our next slide. We'll talk about just a few specifics of how much clinical change or how much change that we saw on the assessment tools for each of these individual comparators. So if you'll move to the next slide. So I'll just take one moment to orient you to the slide. So the top of the slide indicates the medication and the comparator. You can see within the green the number of clinical trials and then the risk of bias associated that was assigned to the clinical trials as part of that. And then the grade assessment. And then you can see some of the specific outcomes that we want to talk about. So I wanted to orient you to this slide because the next 106 slides or so are all structured the same way. So I wanted you to be familiar with that. I'm just kidding. We don't have that many slides. I know. All right, but for abrocitinib and placebo, oh, yeah, sorry, I hadn't gotten there. For abrocitinib and, no, sorry, back. There we go. For abrocitinib and placebo, we had 4 randomized controlled trials. We wanted to show that it was, or we wanted to show, but it did show that it was more efficacious than placebo in adults for IGA and for an outcome of EASI-75. And so what the EASI-75 is at least 75% improvement from the EASI score from baseline. So for IGA, an IGA of 0 or 1, which indicates no disease or minimally active disease at 12 weeks. For abrocitinib, you can see 38 to 44% of participants achieved an IGA of 1 or 2. For placebo, that was 5.8 to 9%. For our EASI 75, again, that 75% improvement at 12 weeks. For abrocitinib, you can see almost 2/3 of participants achieve that goal, whereas 10 to 15% of participants in the placebo groups. So our next slide, please. Here we have abrocitinib versus dupilumab, as well as there was a placebo arm in this study. There was only one randomized controlled trial that had this comparison set. You can see again for the IGA of 0 or 1, for abrocitinib, roughly 50% of participants achieved that particular therapeutic goal. Just over a third of participants for dupilumab and 14% of participants for placebo. And for EASI 75, again, abrocitinib, almost half of participants there. Dupilumab, again, just over a third of participants. And then placebo, nearly 13% achieved that EASI of 75 at 16 weeks. Our next slide. So one of our older agents, azathioprine versus methotrexate. And so for this particular agent, you can see that the grade was assessed as low, and that reflects back into that color table that was a little bit earlier. We saw that azathioprine was equally as efficacious as methotrexate when it comes to SCORAD and IGA assessments over 12 weeks. And I've listed there some of the SCORADs, and this actually had long-term follow-up data. For SCORAD at 12 weeks, we saw a drop of approximately 22.5 points in each group. And in the SCORAD at 5 years, we saw a 32-point drop, and that was from a baseline of roughly 55. For azathioprine, we saw similar adverse events reported with that, as well as methotrexate. High levels of gastrointestinal side effects, which shouldn't be a surprise, 55 and 59% respectively. We also saw high levels of blood count abnormalities, in particular a lowering or impact on white blood cells. 77% of participants in the azathioprine groups actually reported changes in white blood cells. So next slide, please. For azathioprine versus placebo, we saw that azathioprine was more efficacious than placebo up to 5 years. One of the things that was noted was improvements in sleep disturbances and work disruption. That was specifically indicated, and that was statistically significant. And azathioprine, as no surprise, reported higher adverse events than placebo with a high level of gastrointestinal effects. And with this, we also saw, again, high levels of lymphopenia with azathioprine. 43% of participants had a drop in white blood cell counts on azathioprine therapy. Next slide, please. Another one of our more classic agents was cyclosporin versus methotrexate. This one, the grade was very low. Cyclosporin was superior to methotrexate as assessed by SCORAD 50. Similar to EASI 75, a SCORAD 50 indicates an at least 50% improvement in the SCORAD from baseline. For cyclosporin, we actually saw 42% of participants achieve a SCORAD 50 at week 8, whereas for methotrexate, only 80% of those achieved that particular therapeutic goal of a SCORAD 50. Cyclosporin was similar to methotrexate, though, in pediatric patients on SCORAD at week 12. So you can see with cyclosporin and methotrexate, similar reductions in SCORAD in pediatric patients. Next slide, please. For cyclosporin versus mycophenolate, one randomized controlled trial, and this had a grade of very low. We saw similar efficacy of cyclosporin and mycophenolate over 48 weeks. One sort of therapeutic note was participants noted slightly quicker onset with cyclosporin, and SCORAD was changed approximately 20 points in both treatment groups. So as you can see, maybe from some of the previous data that we presented, a 20-point reduction maybe is in line or maybe even a little on the lower side for some of those previous therapies mentioned. Participants reported less prednisone use with cyclosporin, so they needed less rescue corticosteroids, but there were some notable adverse events with cyclosporin compared to mycophenolate, including anemia and excessive hair growth in patients. Next slide, please. For cyclosporin versus placebo, we saw that cyclosporin was more efficacious than placebo, but the assessment tools used were ones that were previously used and maybe not used as commonly or reported as commonly anymore, such as the rule of nines area assessment. High rates of adverse events were reported in the cyclosporin group of 12 to 23, and more discontinuations occurred in the placebo groups due to lack of efficacy. So that can make it sometimes a difficult assessment or a difficult comparison to make if we see high discontinuation groups with or high discontinuation rates in one group compared to another. Next slide, please. So cyclosporin versus prednisolone. So we saw an initial response that was about the same between the two groups, but cyclosporin did report superior efficacy in the measure of stable remission. So that was over a longer period of time. This study was actually ended early after a pre-planned analysis because we saw cyclosporin being more efficacious over that stable remission phase. And patients in, or the participants in cyclosporin group reported higher rates of common cold skin infections and loss of skin sensation. Next slide, please. So cyclosporin versus tacrolimus. So we had one randomized controlled trial that made this head-to-head comparison. Tacrolimus was more efficacious than cyclosporin during the first 5 weeks of treatment, and you can see the change in the SCORAD score at minus 52 points and minus 57 points. But after 6 weeks of treatment, this change was no longer significant, and both of them demonstrated similar efficacy through the rest of the study. And there were very few adverse events reported, only 4 in each group of 15. You can see that this was a very small study, and thus part of why this had a very low grade on certainty of evidence. Next slide, please. So for omalizumab versus placebo, we saw that omalizumab was more efficacious than placebo at 24 weeks. However, it didn't actually achieve the minimum clinically important difference that was established in the study of minus 8.7 points. And the actual difference that was achieved was minus 8.3 points. And I wanted to pause on this and really emphasize that of all the studies, the 40 new studies that we found, this is the only one that actually listed a minimum clinically important difference established by the investigators. So this is at least somewhat notable as a takeaway for us today. The quality of life assessment actually was superior, and it was improved more or beyond the minimum clinically important difference that was defined by investigators in this case, so they did actually achieve the therapeutic goal. So worsening of atopic dermatitis was noted as an adverse event, and so we saw high total reports in both of those groups. And for gastrointestinal issues, you can see roughly 20% of participants reported that in both the omalizumab and the placebo groups. Next slide, please. For pimecrolimus and topical corticosteroids, this study actually enrolled infants from 3 to 12 months. Both groups actually saw a rapid improvement and a reporting success as defined as an IGA of 0 or 1 by week 3. Nearly half of participants in both groups reported that treatment success. This is a 5-year follow-up study. So at the end of the 5 years, nearly 90% of all treated participants in both groups achieved that IGA assessment of 0 or 1. One of the items that they did assess was topical corticosteroid use. And so participants in the pimecrolimus group actually used the product a median of 224 days over the 5 years. And so in the other, they used the topical corticosteroids in the topical corticosteroid comparator group, a median of 178 days. So common adverse events reported in both were nasopharyngitis, fever, and bronchitis. Next slide, please. One of our newer agents, ruxolitinib versus placebo. So ruxolitinib was superior to placebo based on EASI at 75. At 8 weeks, you can see 51% to 78% of participants achieved that EASI 75, and in the placebo groups, roughly 25% of participants actually achieved an EASI 75. Participants in ruxolitinib were also more likely to achieve an IGA of 0 or 1, and you can see that for the 2 studies that we had, in one of those, the odds ratios, the likelihood to achieve an IGA of 0 or 1 was 7.5, and in the other, the odds ratio was 15.8, and you can see the attendant confidence intervals associated with that. Next slide, please. For tralokinumab, which again is one of our newer kids on the block, So we had 4 randomized controlled trials. Study periods were up to 52 weeks, and we had a relatively large participant pool with almost 2,200 unique participants. So tralokinumab 300 milligrams showed significant but inconsistent results. So for an EASI of 75, you can see that for tralokinumab, anywhere from 25 to 56% of participants achieved that therapeutic goal, whereas in placebo, 11.5 or 11.4 to 35.7% of participants achieved an EASI of 75. So you can see that for some of the studies, the lower end of the tralokinumab effectiveness and the higher end for placebo response actually overlap a bit. So that's what we mentioned, or what we mean when we say inconsistent results. Quality of life was assessed with the Dermatologic Life Quality Index. That was significantly improved at 12 weeks, and you can see the effectiveness there. Placebo, a 3-point improvement with tralokinumab, an almost 7-point improvement from about a 13-point baseline. Next slide, please. All right, these are in alphabetical order, so we're in the U's, so we're almost there. Hang in it. So for upadacitinib versus dupilumab, we see superior efficacy of upadacitinib in achieving an EASI of 75 at week 16. For upadacitinib, we see a 71% response rate. For dupilumab, a 61% response rate. So that's a relatively high response rate for upadacitinib. And more participants reported hepatic disorders and elevated creatine phosphokinase in the upadacitinib group compared to dupilumab. Next slide. All right, upadacitinib and placebo. So we see that upadacitinib was superior to placebo for both EASI and IGA. For upadacitinib, 52 to 62% of participants achieved an IGA of 0 or 1, and for placebo, roughly 5 to 10% of participants. For EASI 75, upadacitinib 73 to nearly 80% response, and placebo 13 to 26% response. So a relatively high response rate for upadacitinib, both in this one and in the study that was mentioned in the previous slide. Next slide, please. All right, so we've made it through our FDA-approved therapies. Let's take a look at the findings for our pipeline therapies. Next slide, please. So for baricitinib and placebo, we see that baricitinib was superior to placebo again as IGA and EASI of 75. You can see with IGA of 0 or 1, for baricitinib, an almost 17 to 31% of participants achieved that therapeutic goal, as opposed to in placebo 5 to 15%. So overall for IGA 0 or 1, you can see a lower overall response rate doing an indirect comparison than maybe with some of the others that we've talked about today. And same with EASI 75 for baricitinib, 25 to 48% of participants achieved that therapeutic goal, and in placebo, almost 9 to 23% of participants. So this actually did include a 68-week extension study, so we actually have longer data for baricitinib than a lot of the newer agents that we've talked about. And discontinuation rates were actually similar between baricitinib and placebo. Next slide, please. For lebrikizumab and placebo, we had 2 randomized controlled trials for this. We can see that lebrikizumab was superior to placebo, again, by IGA and EASI. And that has been one nice feature for the newer agents, is to at least see consistent outcomes reported so that you can make those indirect comparisons. So for an IGA of 0 or 1 for lebrikizumab, you can see roughly a third to a half of participants there achieved that IGA goal. And for placebo, 15 to almost 20% of participants. For EASI 75, lebrikizumab, roughly 60%, and then for placebo, 24 almost to 30% of participants achieved that goal. So high placebo response rates in these groups of participants. Quality of life, however, was not consistently improved compared to placebo. And that was one of the elements that you can refer back to the grade table that we had earlier in the presentation, why this would lead to a downgrading on the certainty of evidence because of that inconsistency. And adverse events such as injection site reaction were mild to moderate and similar to placebo. Next slide, please. For nemolizumab, we had 3 randomized controlled trials. Once again, we see that it was superior to placebo in IGA and EASI. For IGA of 0 or 1, nemolizumab, roughly a third of participants there experienced that therapeutic goal, whereas with placebo, 7 to 21%. And we see there, P is variable within studies. So some studies demonstrated a statistically significant difference and some didn't. And that's what that means by P variable. And the same for the EASI of 75. We see for nemolizumab, 45 to 50% of participants responded with an EASI of 75, placebo 16 to 25. But once again, that didn't achieve statistical significance in all of the studies that were published. But quality of life compared to placebo was improved. Next slide, please. All right, so the findings for our ongoing studies. Next slide. We only have 3 of those, or excuse me, ongoing studies. So for our ongoing studies, we identified 32 ongoing studies. You can see for our FDA-approved therapies, we have abrocitinib with 4, crisaborole with 2, dupilumab 4, ruxolitinib 1, tralokinumab 4, and upadacitinib 2 studies. For the pipeline therapies, which is on our next slide, we can see that for baricitinib, 4 studies, lebrikizumab 5, nemolizumab 4, and tradipitant, they have 2 ongoing studies. Sample sizes range from 228 to almost 1,800 participants, and nemolizumab has a small substrate study in progress to assess for drug interactions. All right. Next slide. To our discussion. So next slide, please. The way that we framed this discussion, we wanted to talk about those that had moderate to high certainty of evidence and kind of group those together. So that doesn't necessarily mean that they're more efficacious, but just that the level of evidence for these were a little bit higher. So for abrocitinib, we felt that it was efficacious compared to placebo. For the baricitinib, once again, efficacy outcomes were superior to placebo. But if we did make indirect comparisons, particularly to some of the newer agents, baricitinib seemed to have overall lower response rates. Upadacitinib was superior to placebo and dupilumab. And again, making these indirect comparisons, but using common endpoints and relatively common study durations, upadacitinib tended to have higher response rates than some of the other therapies that we evaluated. And as no surprise, the newer agents had, they demonstrated efficacy with larger studies than those older agents that we had. Next slide, please. So those that had low to very low certainty of evidence, azathioprine did show efficacy, but had a lot of adverse events and high discontinuation rates when studied long-term. Cyclosporin was also generally efficacious. The studies associated with cyclosporin tended to have a high risk of bias and also a lot of adverse events. Again, that lymphopenia was something to be noted with cyclosporin. Lebrikizumab was superior to placebo, but generally speaking, effect sizes were relatively small compared to some of the other particularly newer agents. And nemolizumab showed inconsistent results in efficacy study to study, not all of those achieving statistical significance. Omalizumab was superior to placebo, but it did not meet that minimum, boy, that's hard for me to say today, minimally clinically important difference that was defined by investigators at 24 weeks. And omalizumab and pimecrolimus have long-term study data up to 5 years, in which 90% of participants treated showed treatment success. And next slide. I'll be happy to take any questions that you have.
Thank you, Wesley. Really appreciate it and the flexibility today as well. With that, I think we're ready to go on to our stakeholders. I'll remind anybody if they are not one of the 3 that are pre-registered, they can raise their hands and we'll get to them. But I already was excited to get connected with our first stakeholder, which was Margaret Ullman of AbbVie.
Okay, I think I'm unmuted. Can you hear me?
I can hear you. Thank you very much.
Well, first I would like to thank Dr. Lindsay for that exceptional report. This is a lot of information going on in the atopic derm. My name is Dr. Margaret Ullman with Medical Affairs at AbbVie. I want to thank you so much for allowing me a few minutes to provide information on upadacitinib with the brand name Rinvoq. My focus will be on the newest indication. Rinvoq has been FDA approved to treat patients 12 years and older with refractory, moderate to severe atopic dermatitis, not adequately controlled with other systemic medications, or when the use of those therapies is inadvisable. Treatment should be initiated with 15 milligrams taken orally once daily. If an inadequate response is not achieved, providers should consider increasing the dose to 30 milligrams a day. Atopic dermatitis is the most common and most severe type of eczema and is characterized by itchy and inflamed skin. Providers and patients with moderate to severe AD are looking for a treatment that will offer rapid reduction in itch and pain, along with the lessening of inflammation, redness, and thickening of the skin. Rinvoq has differentiated itself from other medications currently available for the treatment of atopic dermatitis. Rinvoq at both 15 and 30 milligram daily doses met all primary and ranked secondary endpoints in 3 pivotal trials. Measure Up 1 and 2 looked at monotherapy treatment, and Add Up was a trial that evaluated Rinvoq in a combination with topical corticosteroids. In these studies, the investigators noted a rapid onset of action. Over 2/3 of patients saw a statistically significant 75% improvement in skin symptoms after 16 weeks, and a significant reduction in itch was seen as early as day 2 with Rinvoq 30 milligram and day 3 with 15 milligram. In all 3 studies, Rinvoq demonstrated disease control for adults and adolescents through the double-blind placebo period and with and without use of topical corticosteroids. Rinvoq has a well-studied clinical profile with over 7,500 patients studied in rheumatoid arthritis and psoriatic arthritis, and now with over 3,200 additional patients in the AD phase 3 program. The safety in the AD studies was consistent with the previous trials in RA and psoriatic arthritis. This has been only a short review. Please review the prescribing information for full efficacy and safety information online at rxabbvie.com. I want to close by respectfully asking that Rinvoq be added to the state preferred drug list for all indications, including atopic dermatitis. Thank you for your time and consideration. I'd be happy to answer any questions that you might have at this time.
Thank you very much. For our next one then is Min Wen of Pfizer. We have 2 topics for this one, so it'll be 5 minutes of time that we're able to give to the stakeholder.
Thank you. Just checking to see if you can hear me.
We can hear you. Thank you.
Yep, fantastic. I believe it's technically still the morning, so good morning to the committee members. My name is Min Wen. I'm one of the field medical directors with Pfizer's dermatology group. So I'm here today to provide a medical presentation on 2 products for atopic dermatitis. So the first product is Eucrisa, which is also called crisaborole. It is a topical non-steroidal for the treatment of mild to moderate atopic dermatitis. It is indicated for adults and pediatric patients aged 3 months and older. The contraindication for Eucrisa is if the patient has a known hypersensitivity to crisaborole or any component of the formulation. The safety and efficacy profile of Eucrisa was established in 2 double-blind randomized vehicle-controlled studies. Additionally, Eucrisa was studied in a 48-week open-label safety extension study in patients 2 years of age and older. Safety assessments included adverse events, vital signs, ECGs, clinical lab parameters, and local tolerability. The most common adverse event occurring in greater than or equal to 1% of subjects was application site pain. Additionally, use of Eucrisa in pediatric patients ages 3 months to less than 2 years was supported by data from a 28-day open label safety and PK trial in 137 subjects. So I'd like to ask the committee to consider Pfizer's request to retain Eucrisa on the PDL. So the second drug I'd like to present on is called Cibinqo, or abrocitinib. It is a Janus kinase inhibitor, or JAK inhibitor, indicated for the treatment of adults with refractory, moderate to severe atopic dermatitis whose disease is not adequately controlled with other systemic drug products, including biologics, or when use of those therapies is inadvisable. Cibinqo is not recommended for use in combination with other JAK inhibitors, biologics, or other immunosuppressants. It is contraindicated in patients taking antiplatelet therapies during the first 3 months of treatment. Serious infections, mortality, malignancy, MACE, and thrombosis have occurred in a trial involving another JAK inhibitor in RA patients. The recommended dosage is 100 milligrams orally once daily, and a 200 milligram oral once daily dose is recommended for those patients who are not responding to the 100 milligram dose. It can be used with or without topical corticosteroids. The most common adverse reactions in subjects receiving the 100 and 200 milligrams in the trials included nasopharyngitis, nausea, headache, herpes simplex, and increased blood CPK. So the efficacy of Cibinqo as monotherapy and in combination with background topical corticosteroids were evaluated in 3 randomized double-blind placebo-controlled trials in 1,600 subjects 12 years of age and older with moderate to severe atopic dermatitis as defined by typical characteristics, including the IgA, the EZ, body surface area involvement, and also the peak pruritus numerical rating scale. In the 2 monotherapy and combination trials, the percentage of patients with an IgA score of clear or almost clear on a 5-point scale with a reduction from baseline of 2 points and a greater than or equal to 75% improvement in the EZ was statistically higher in both active abrocitinib arms compared to placebo. The proportion of subjects achieving an itch improvement in the PPR-NRS at week 2 was also higher in subjects treated with Cibinqo compared to placebo in all 3 trials. So in conclusion, atopic dermatitis continues to have a high unmet medical need and is costly to manage. To further manage this disease, we need alternative agents available. So by adding an orally administered medication, we'll offer an additional treatment option for these patients with moderate to severe atopic dermatitis in the Washington Medicaid population. So based on the efficacy and safety of Cibinqo, I ask that you consider adding Cibinqo to the PDL. Thank you to the committee for your time today. I'd be happy to respond to any questions.
Thank you. Committee, if you have any questions, just let me know. But next up will be Valerie of Leo Pharma.
Hi, can you hear me okay?
We can hear you. Thank you. Go ahead.
Well, good morning, everyone. I'm Valerie Ng, Medical Outcomes Liaison at Leo Pharma. Really glad to have this opportunity to be in front of you virtually and share with you information on Adbry. So Adbry, or tralokinumab, was approved by the FDA on December 27, 2021. It's a first-in-class human high-affinity monoclonal antibody that specifically neutralizes IL-13 or interleukin-13. IL-13 has been shown to be a key cytokine driving inflammation in atopic dermatitis or AD skin. And this new biologic is indicated for the treatment of moderate to severe AD in adult patients whose disease is not adequately controlled with topical prescription therapies or when those therapies are not advisable. And Adbry can be used with or without topical corticosteroids. The recommended dosage is an initial dose of 600 milligrams via subcutaneous injection, followed by 300 milligrams every other week. Now, a dosage of 300 milligrams every 4 weeks or monthly may be considered for patients below 100 kilograms who achieve clear or almost clear skin after 16 weeks of treatment. Safety and efficacy profile of Adbry has been established in the extra clinical program for adults with moderate to severe AD, and the efficacy was assessed in over 1,900 adult patients in the 3 pivotal trials where Adbry demonstrated superiority over placebo for primary and secondary endpoints of IGA 0/1, EASI-75, and worst daily pruritus score at week 16, and Adbry maintained responses at week 32 and week 52. Most common adverse events reported in the pivotal trials were non-serious and mild or moderate in severity. The overall frequency of AEs was comparable across treatment groups and did not increase during prolonged treatment of up to 52 weeks. Most common adverse reactions were upper respiratory tract infections, conjunctivitis, injection site reactions, and eosinophilia. Overall, Adbry represents a new option in the treatment paradigm for moderate to severe AD in adult patients. With the option to provide this maintenance dosing of every 4 weeks for eligible patients, their chronic disease may be managed with fewer doses. Therefore, we would ask that the committee consider adding Adbry to the PDL as a preferred product for adult patients suffering from moderate to severe atopic dermatitis who had an inadequate response to topical prescription therapies. Thank you all very much for your time. And are there any questions I can help answer?
Thank you very much. I'll now kind of pass it over to Lita, and we can go to anybody. I think we have one person I can see who would like to present.
Yeah, this is Lita. Brandon Yip. Brandon, you're unmuted. Can you unmute yourself? Hi, Brandon, you're unmuted. Brandon, can you unmute yourself? Brandon, if you can enter in the chat if you're having, oh, you can't unmute, okay. Do you want to type your question in the chat? You might be double muted on your computer as well as on the Teams meeting. Okay. Well, Brandon, you're unmuted on our end.
Hello?
Hi.
Hello? Oh my goodness. I'm so sorry
Great.
about that. I was trying to unmute, remute, and I ended up just hanging up and trying again. I apologize for the technical difficulty. I know that time is valuable. I just wanted to make 2 really quick comments. Again, my name is Brandon Gipp. I am the Medical Managed Care Director with Sanofi Genzyme representing dupilumab. And I just wanted to comment on just some recent information that we have on dupilumab in atopic dermatitis. Thank you for Dr. Lindsay with a very thorough, examination of all the clinical data, strength of studies and all that. One thing I wanted to add one of the two things I just wanted to add very quickly was the recently released ICER report at the end of 2021. The conclusion of that report stated that dupilumab is associated with favorable long-term cost effectiveness compared with JAK inhibitors and tralokinumab in adults with moderate to severe AD. They did indirect treatment comparisons, and they conducted that there was insufficient evidence to support superiority of abrocitinib and upadacitinib over dupilumab. And then the other quick thing I just wanted to add is that we recently completed a 1-year real-world evidence study called Relieve AD. It looks at a number of factors, efficacy and safety. It kind of aligns with the ICER report. We haven't seen any additional safety signals with almost 5 years of experience on the market across multiple indications. And, if you guys are interested in seeing that manuscript, I'd be happy to, provide that. And I think one point that I wanted to bring to the committee's attention is that, it did reaffirm that the very positive adherence and persistence numbers, right? Across a 30-day grace period, adherence was about 91%. And patients that discontinue the drug, understanding that atopic dermatitis is waxes and wanes when patients experience flares and remissions. Patients restarted the drug within 116 days. So I just wanted to, make those 2 points with some new data that we had for dupilumab in atopic dermatitis. Thank you guys, and I apologize again for the technical difficulties.
This is Lita Vasquez. I see that John McKay, the committee member, has a question for Dr. Lindsay. So John, if you could turn on your camera and ask your question.
Yeah, Dr. Lindsay, I was just wondering, some of the older agents in terms of the comparisons of the tacrolimus, was that the oral or the topical formulations that were kind of head-to-head comparisons?
For the for the tacrolimus, I believe that was the topical formulation, but let me just double check. I've actually got my studies right here very quickly. I can give it a quick reference and double check on that. Yep, I was right. It's the ointment versus oral cyclosporin.
Thank you.
All right, well, thank you, everybody. I think we are ready to consider our motion then. Thank you, Lita, for bringing that up.
This is Susan Plotable. I just have a question. With this drug class, there's, topicals, there's oral agents, there's injectables. How are they preferred? I mean, do they have to fail another topical agent, before they can go to oral? Or, I mean, how is that, determine which are preferred based on their route?
Hey, Susan, this is Donna. We have clinical policies along these where we typically make them try some of the older topical agents before we move on to the more systemic agents, before they try like the monoclonal antibody type agents. So for instance, Dupixent, they have to try, I think, a steroid and either tacrolimus or pimecrolimus before they can get to like dupilumab.
Okay, thank you.
And they're in different drug classes, so which is why we have a clinical policy. It's not a tried and failed. They are all in different drug classes on the PDL, I believe. At least for the Medicaid PDL.
And this is
And then just.
I was going to say, yeah, the same for UMP. So, we do have our clinical policies, posted online that would go into more detail, but we'd have to, find them individually and then, look through them. So it is really dependent kind of in their drug subclass rather than looking at this kind of disease state as a whole.
This is Susan again. Yeah, and then plus, some of the adverse events related to, like cyclosporine, for example. I don't know how that factors in, if that's even something they have to try and fail. I would hope not, based on side effects. I mean, how does that even factor in? This like cyclosporine use, is that considered preferred? I guess my question is, would they have to fail cyclosporine before they could try another agent in this class?
Hi, Susan, this is Donna again. For Medicaid, the answer is no. We don't consider cyclosporine. It's not, we are considering that more of an immunosuppressive agent rather than an atopic dermatitis. So it's not required in the Medicaid program as a drug for to get to some of the other medications.
Thank you.
This is Laura Bestie. Can I just ask a question for clarification based on what Susan asked? For the committee, when we're approving these agents, we are just approving them as an addition to the formulary, not their place in the formulary. Is that correct?
Correct.
And then who decides their place within the formulary?
So this is Donna. After you make your motions, we have these, like I said, split up into their relative drug classes based on their mechanisms of action, and then we do a cost analysis. If you say that they're safe and efficacious and interchangeable, we will, draw the line and pick, several or one or two or more of the least costly products, and we'll do that drug class by drug class to determine if they're preferred or non-preferred. And this is Donna again. Susan, to correct myself, cyclosporin is one of the drugs, one of 4 drugs for, at least for Dupixent, that is required for trying to get to Dupixent. So methotrexate, cyclosporin, azathioprine, and mycophenolate would all be they need to try one phototherapy or a systemic corticosteroid or one of the immunosuppressants.
This is Susan again. Would they also, maybe the provider would be able to say they wouldn't be a candidate for that medication based on the side effect profile? Okay.
If one of those drugs was not appropriate for them to take from a clinical standpoint, then that would be taken into consideration, yes.
Kavita Chawla here. I guess the one aspect that I am struggling with a little bit is understanding how, so we're calling them all safe and efficacious in that, the harms, specifically the safety part, where the harms don't outweigh the benefits. But it seems to me from this incredible drug review that was done that some seem to have more safer adverse effect profiles than others do, kind of linking back to what Susan also said, that, the 4, I think, drugs that you listed, Donna, that need to be, at least one of them need to be tried in order to go into one of the monoclonal antibodies. All of them have a major immunosuppressive impact. And so it's like, is it that, so for example, taking the simplest one, taking a systemic corticosteroid, yes, it would probably improve their severe atopic dermatitis, but because it's not something that can be used long term, is that considered a tried and fail under our language to get approval for one of the newer agents?
So at this time, systemic steroids are not required. And let me go back for a minute. We're talking about the Washington PDL here. So typically the committee doesn't make recommendations as far as our policies are concerned. It's just based on the preferred, non-preferred status. When we review the Dupixent policy or the atopic dermatitis policy, I think that's a better time for this particular conversation.
So the discussion regarding preferred versus non-preferred, is that a recommendation that is discussed right now, or that's also discussed at the time of policy discussion?
We make the preferred and we make the motion of their safety and efficacy and their interchangeability as the P&T committee, in a separate motion and a separate, from the Drug Utilization Review Board, which discusses the actual policies for Medicaid.
This is Lee Vasquez. The Washington PDL is used by Uniform Medical Plan and Labor and Industry. So the Washington PDL only has about 30 drug classes, which are the highest cost drug classes. And UMP and Labor and Industry will each make their own decisions about if the drug is included, if it's preferred or not, but these are the suggestions from the committee.
And this is Donna, and for Medicaid, we follow your motion guidance, but we won't end up with the same preferred drugs necessarily as UMP and LNI would for this particular classes. And that's because of the Medicaid program costs are much different than the Uniform Medical Plan because of the federal rebate program.
This is Lee Vasquez. If you don't feel that one of these drugs or some of these drugs are not safe and efficacious, you don't have to list them. So we can start this off here, and then if you want to include all of the drugs or just a few of them, I can list those as safe and efficacious.
So this is Jordan Storhaug. I just kind of going to try to direct us here and trying to talk about the safety and efficacy of it. I think right now I would think we'd be planning on listing all the drugs reviewed as safe and efficacious. So that's probably where we're starting. So if people feel differently, please go ahead and speak up. And then maybe more difficult is what we decide to do about the therapeutic interchange as well.
So I'm a little curious, this is Laura Bestie, about, so why was cyclosporine and mycophenolate and some of the older medications not included on the previous review in 2018, but it's being included now because these are not new medications?
So Donna, or this is Donna, the report has changed. So the original report only included the newer products, and the older report, or the newer report, I think included additional drugs. I'm just trying to navigate to the actual report to see what
this is Lee Vasquez. In the motion here, what's previously listed would be just the drugs that are reviewed in that report. So the ones that are bold here are new this report.
And just a small note, there needs to be an E on mycophenolate on the end.
Thank you.
Yeah, so this is Donna again. So we just expanded this report Because a lot of these drugs are in different, they have multiple indications. Some of them are, rheumatoid arthritis, they have a variety. So when we switched from having kind of what we called the TIMS report, and we broke them out by indication. With the atopic dermatitis, we decided we wanted to be able to look at the comparative efficacy of these, more expensive biologic drugs compared to the older, the products that were traditionally used for treating atopic dermatitis. And so that's why the older drugs were included in this particular version of the report.
And this is Luke from HCA. I work a lot on the UMP plan, and we don't require these older drugs as a step through to the newer drugs for use in atopic dermatitis, if that helps. And by older drugs, I mean the cyclosporin, mycophenolate, azathioprine.
And as far as therapeutic, this is Donna again, as far as therapeutic interchange goes, in the past, when we've had drugs across multiple drug classes or mechanisms of action within a single report, you have, the committee has made comments that they're, therapeutically equivalent and interchangeable within their own, drug subclass. So the calcineurin agents would be interchangeable. The methotrexate and azathioprine might be interchangeable, and some of the other MABs, if you feel that they're interchangeable. We wouldn't be interchanging cyclosporin instead of like crisaborole. That would not be happening.
Kavita Chawla here. I think I like that suggestion of including the language of therapeutic interchangeability within the drug class, if the rest of the committee also agrees with that.
This is John McKay. I'd just like to comment that I think I'd caution some of the therapeutic substitutions of the older agents like azathioprine or mycophenolate, just given the needs for therapeutic monitoring.
This is Laura Bestie. Along those same lines too, could you make it a little more generic since it hasn't been reviewed and some medications can't be interchange? You could say the medications could be subject to therapeutic interchange in the Washington preferred drug class as appropriate. And then it could be a little more generic and then for a review later on.
This is Donna again, and we can say that a lot of these drugs, the older ones they're generic and they don't require prior authorization, so they're likely preferred already. So there wouldn't be interchange happening. Some of the other drugs, I think for Medicaid at least, tacrolimus and pimecrolimus, they I think there's a significant difference in cost, and I forget which one's cheaper. So there, one's preferred and one's not. But so yeah, I think that's okay. But there's therapeutic interchange happens at the pharmacy. So by the pharmacist who's dispensing the drug, and so we wouldn't have a way of saying, when it's appropriate or not appropriate. We just know that we get a prescription. We don't know what it's been prescribed for. It could be for psoriasis, for all we know.
So this is Susan again. So Donna, are you saying it's better to leave that language out and not have it be, not even say anything about medications in the therapeutic subclass can be subject to therapeutic interchange because it's going to probably happen anyway?
I guess what I'm trying to say is that, if you want the pharmacist at the time of dispensing to be able to dispense a preferred drug instead of a non-preferred drug without having to contact the doctor to get a new prescription, because that's what therapeutic interchange means, then you need to say that they're interchangeable. If you don't feel that they're interchangeable and you don't feel that it's appropriate for the pharmacist who's dispensing the drug to make that determination, then you can just say they should not be subject to interchange. But for example, the calcineurin inhibitors, before you had mentioned, the committee had determined that those were interchangeable, and that the other two products that were reviewed were not. So if you feel comfortable with the calcineurin agents but not the others, then you could leave it as it was stated before and just call out the calcineurin agents.
This is Jordan Storehawk. That's probably what I would be leaning towards doing is just having the calcineurin inhibitors subjected to the therapeutic interchange. And part of the reason why that is it probably doesn't matter for some of the old ones. And I don't know if I'm convinced that there isn't a difference between our monoclonal antibody options. I think I would want to be contacted, let them know that we were going to need to use another one.
This is Laura Bestie. I think at this point, without having had the time to review that information, I wouldn't want to make that decision.
Well, this is Susan Flattabo. I'll go ahead and do the motion then if there's no more discussion. After considering the evidence of safety, efficacy, and special populations for the treatment of atopic dermatitis, I move that abrocitinib, azathioprine, crisaborole, cyclosporine, dupilumab, mycophenolate, omalizumab, pimecrolimus, ruxolitinib, tacrolimus, tralokinumab, and upadacitinib are safe and efficacious for the treatment of their approved indications. The calcineurin inhibitors can be subject to therapeutic interchange in the Washington PDL.
This is Virginia Bucola, and I second.
Thank you. All in favor, please say aye.
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 Anyone dissent, please say nay. Thank you. So then I'll kind of reach out to Lita. Do you think we want to take lunch at this time and follow up with our second generations after antipsychotics, or do you think we need
Yeah,
to?
this is Lita Vasquez. I have checked with OHSU, and our presenters are okay if we take a half-hour lunch now and then reconvene. So it's about 12:25. So why don't we reconvene at 12:55?
Okay, and Lita and Jordan, this is Donna. I just want we're going to reschedule the second generation antipsychotics and then just go on to the ADHD drug class since it was a carryover from the last meeting. So we're gonna try to follow the agenda as published here from here on out.
Be back to the old schedule. Sounds like a plan.
Great.
Okay, thank you. And I'll put up a sign that we'll be reconvening at 12:55. Hi, this is Lita Vasquez. Shannon and our next presenters, if you want to go ahead and test your cameras and mics, go ahead. Can't hear you, Shannon.
Testing, this is Andrea Vintro.
Yes, I can hear you, Andrea.
Great, thanks.
Shannon, you could also call in with your phone. And while we're waiting for that, I will pull up the presentation.
I think we're just still waiting for our speaker and be able to get connected with that. I can answer one question from the chat. For our stakeholders, we will allow you to be able to unmute yourself right before it's your turn to speak. So being unable to unmute yourself right now is okay. Lita, do you think we're ready to go, or do we need to work with Shannon still?
Andrea, I guess that's up to you if I don't know who starts the presentation.
I am starting, although I think it might be great to have sort of confirmation because Shannon is primary author, going to be going through the findings, discussion, etc.
Okay. The other thing is when Shannon calls in, I'm just going to need to know her phone number to unmute it, but let's see. There's only one other.
I think she had troubles with her mic working with Teams, so I don't know if anyone has any suggestions on that route, but
Curtis, I've unmuted you. Okay, now Laura can't unmute herself. Let's see, Laura, I would double check that you're not double muted on your computer and then also on your phone. Okay, Laura, thank you, Laura Crocker, fix that. Curtis, I see your hand raised. I have unmuted you if you can unmute yourself. Okay, and for stakeholders, I will unmute you when your name is called to speak. So don't worry about not being able to unmute yourself right now. Oh, Curtis cannot. Okay, hang on.
All right, thanks, Lita. It looks like I can unmute now. So Shannon's still trying to work this out. I know Andrea is up first. I would recommend that let's just go ahead and get going with the presentation. Andrea, you can kick off your section, walking through the background and methods. And if at that time Shannon's still having audio issues, I will go ahead and do the presentation for her for the findings and conclusions, given my audio seems to be working okay. How does that sound, Lita?
That sounds good. And if I don't know if it changes anything if I move Shannon, what I just did for you, if that would help her microphone at all. Moving to presenter instead of just unmuting her. But I don't see Shannon in, hang on just a second, the list is probably longer. Okay, let me
Hi,
move
this is
Shannon.
Shannon. Can you hear me?
Yes.
We can hear you, Shannon.
Okay, great. Okay, I will go back to being muted for the moment then.
Okay, great. Okay, thank you guys.
Yeah, so with that, then Andrea will go ahead and start the topic of ADHD and allow you to start your presentation. Thank you.
Wonderful. So everyone can hear me at this point?
Yes, we can hear you.
We are here, so thank you so much. Yes, my name is Andrea Vintro, and very happy to be here to present this report entitled Pharmacological Therapies for ADHD with my colleague and first author, Shannon Robolino. So we can go to the next slide. So this report will be presented in the format that's outlined on this slide. So I'll walk you across from left to right. So I will start out with some background on the topic, define the PICOS and key questions, and then walk you through our methods section before I turn it over to Shannon, who'll present the findings and then finish up with some discussion and items for you to consider. Next slide. So for some background, attention deficit hyperactivity disorder, or ADHD, is considered a common neurodevelopmental disorder that affects nearly 10% of children and adolescents in the United States, and also from about 1 to 4.5% of adults, and this is according to a 2016 report by the CDC. It has also been reported that over 60% of youth with ADHD are being treated with medication, and 80% of adults are treated specifically with stimulants for their ADHD symptoms. And to note that in adults, prescriptions for stimulants have been on the rise over the past decade, not only for ADHD, but also for anxiety and depression, with the largest increase in the female population between the ages of 25 to 55 years. In 2013, the diagnostic criteria for ADHD was updated with important changes, including an increase in age for the onset of symptoms. So before the update, symptoms had to start on or before the age of 7, and now that's been pushed back up to 12 years. And also the number of symptoms required for diagnosis of ADHD in adults has been reduced from 6 to 5 symptoms. And these changes are really reflecting the newer understanding of how symptoms are manifesting in adolescence through to adulthood. Other diagnostic criteria for ADHD include symptoms that are interfering with functioning must also be present in 2 or more settings, such as the school, the workplace, or other social environments, and symptoms must not be better explained by a different mental health disorder, such as anxiety or depression. And just before we go to the next slide, I want to draw your attention to the green dog-eared page icon in that upper right-hand corner of this slide and several upcoming slides. The page numbers listed within that symbol, they correspond to the pages in the full report where you can find details of the information that we're summarizing for you here today. Okay, so we can go to slide 3. The core symptom domains of ADHD are listed here on the top, and their definitions and inclusion criteria were not changed with the update of that diagnostic criteria. However, the nomenclature did change. So rather than 3 subtypes of ADHD, they're now called presentations. And again, this is reflecting that new understanding for that fluidity of symptoms that they're seeing between the domains across the lifespan. So individuals with predominantly inattentive presentation are challenged with a lack of focus, inattention to details, disorganization when trying to complete tasks or follow instructions. For those with predominantly hyperactive, impulsive presentation, fidgeting, impulsivity, and the inability to sit or stand still for longer periods of time are the most common symptoms, and these behaviors are also increase the likelihood of injury caused by accidents. And for those with combined presentation, of course, symptoms of both inattention and hyperactivity, impulsivity are sort of equally present. Comorbidities with other psychiatric conditions are also common in persons with ADHD, and that overlapping of symptoms across these conditions can present real challenges for clinicians to diagnose and treat appropriately. In children and adolescents, the most common comorbidities are oppositional defiant disorders, learning disorders, and also anxiety. And in adults, the most common include depression, anxiety, and substance use disorders. So treatments for ADHD can include stimulants and non-stimulant medications, of which there are 31 drugs currently approved by the FDA. Behavioral interventions, including skills training and cognitive behavioral therapy, or CBT, are also used to treat ADHD. And to note that clinical practice guidelines do specify that behavioral therapy should be the first line of treatment for preschool age children, and also be included in the overall treatment for older children who are also on medication. Slide 4, please. And so like many other health conditions, the literature does identify disparities for the diagnosis and treatment of ADHD. And these disparities have been found across different race and ethnic groups, genders, age, socioeconomic levels, as well as geographic distribution, such as individuals between rural and urban environments. In general, historically marginalized children, particularly those identified as Asian, Alaska Native, or Native American, are less likely to be diagnosed with ADHD and less likely to receive pharmacotherapy. Other examples in studies are showing that children who are identified as Black are more likely to receive behavioral therapy than other race and ethnic groups. However, they're less likely to ever be initiated on medication. Females are also less likely to be diagnosed with ADHD, and if they are, they're less likely to be prescribed stimulants. And evidence does suggest that different symptom presentations between gender types and gender bias among clinicians are potential reasons for these disparities across gender. Slide 5. So there are some differences in the patterns of prevalence and treatment for individuals who are covered by Medicaid compared to the national cohort. A recent report by the Office of the Inspector General identified a higher prevalence of ADHD in children covered by Medicaid of approximately 13% in a 2014 and 2015 cohort, and this was compared to the national average of 5%. A large study of Medicaid-enrolled children, which was published in 2017, found that children identified as African American were less likely to receive adequate follow-up if they were prescribed medication, and were more likely to discontinue and disengage from treatment compared to those identified as white. Another study found white male children living in a 2-parent household were more likely to be assessed and treated for ADHD compared to their non-white female and single-parent household counterparts. And this was even more pronounced within the population of children enrolled in Medicaid. Gender and racial patterns of disparity seen in children also appear to be similar in the adult Medicaid population. And this last bullet point here refers to a study that found also large variations in treatment regimens in adult Medicaid beneficiaries across different states. Next slide. So on this and the next few slides, I'll go over the parameters and methods that we used to conduct this report. We start with the population, comparators, and study design of the PICOS on this slide. So our population included any individuals with any of the 3 presentations of ADHD. For comparators, we were primarily interested in studies with head-to-head comparisons of different drug treatments. However, for the more recently approved drugs that were not included in the last update of this report, we did include placebo-controlled trials and other standards of care, such as behavioral therapy, as comparators. So this will refer to any new drug that was approved after January 2015, which was that end search date for the last report update. We also did not include studies that compared a brand name with its generic equivalent, or compared multiple doses of the same medication to each other, or explicitly included and focused on multimodal treatments like medication plus parent training, for example. And then for study design, we only included randomized controlled trials, or RCTs. And just to note that in the previous report on this topic, they also included observational studies. So just wanting to confirm and remind you that those study types were not included in this current report. To slide 7. So on this and the next 3 slides, we have the list of drugs that are included for our interventions of interest. I'm not going to read every item here on this list. They're here for your reference, but I do want to just orient you to the slide. So at the top, starting on the left-hand column, we have the generic name or primary ingredient of the drug, followed by the brand name in the middle column, and then the date of FDA approval in the far right column. The interventions in bold indicate new drugs approved since the last update of the report, and your eyes are not deceiving you. Yes, all of the drugs listed here are in bold. So this list is also in order of FDA approval, with the most recently approved drugs listed at the top, and then also by drug category, so shown in that yellow subheader. In this slide, we have the drug category of stimulants, of which there are 27 different brands of stimulants. And I do want to mention here what likely many of you know, that many of these drug brands contain the same active ingredients, but they have some chemical tweaking or additional compounds that allow for a novel delivery system that may allow for an extended or sustained release, for example. Next slide. So this slide, and then we can actually go to slide 10. That list continues. So on slide 10, here at the top, we have the category of non-stimulant drugs, still looking at the interventions, and you can see that viloxazine hydrochloride with that brand name Qelbree is in bold since it was recently approved by the FDA. That's right, yeah, in April of this year. And next we have the drug category of off-label treatments. And just to mention that the FDA approval date in that right-hand column, of course, is for the condition that it was originally indicated for these drugs, not for ADHD, of course. And so here is, on slide 11, is the last slide describing our PICOs for this report, where we list the outcomes of interest. For efficacy and effectiveness, we included select measures for symptom response, functional capacity or performance as in academic or work performance. We looked at quality of life, so this is for the patient as well as for the family, caregivers, and teachers. We looked at time to onset of effectiveness and also duration of effectiveness. Then for harms, we included overall adverse events, discontinuation of the study due to adverse events, and then also serious adverse events. And then we also looked at misuse and diversion outcomes, including those listed here. Next slide. And here we have our 4 primary key questions for the report. So we asked about the evidence for effectiveness and harms of the FDA-approved and off-label pharmacological treatments for ADHD. We asked about the potential differences in effectiveness and harms across demographics, including across age, race, and gender groups, for example, and also across populations with different comorbidities. And finally, we looked for any ongoing studies. So next we'll move to slide 13. So here we have a high-level overview of our methods. So from the previously commissioned reports, we identified all the head-to-head trials for drugs that are currently being used for the treatment of ADHD, and the head-to-head trials of any off-label drug interventions, and then moved them forward for this report. And then all of the study characteristics and outcomes data from those studies that were presented in that prior report were cut and pasted basically into the respective sections for this report. And then if important information was missing, we did review those publications more thoroughly and added any information as necessary. And then we searched Ovid Medline, the Cochrane Library, and other internet sources for studies within the date limits of January 2015 through August 2021. And we also scanned reference lists of relevant systematic reviews for any additional studies. Then for ongoing studies, we searched clinicaltrials.gov and the Cochrane database. And then for quality of evidence, we used 2 independent reviewers to conduct risk of bias assessments for studies that were identified from our database searches. And then for those studies that we moved forward from the previously commissioned reports, the risk of bias assessments were also moved forward, but we did adjust those assessments after reviewing for any conflicts of interest from study authors or funding of the study, because this was not included in those earlier assessments. So for example, if there were meaningful conflicts of interest of drug companies providing financial support to the authors or funding the study, that would have further increased the risk of bias of that study. We also conducted grade quality of evidence assessments on 5 select outcomes, and we did decide to limit the studies that were assessed for each grade outcome to those that included a minimum treatment period of 8 weeks with or without follow-up. And this was done for a couple of reasons. First, it's well known that most pharmacotherapies for ADHD do show immediate effects. However, they may not be maintained over time. And second, it's recommended that these drugs be titrated over a 4 to 6 week period until that optimal dose is achieved, and then that would leave a very short window to perform the actual study, if the total length was less than 8 weeks. Next slide. So as a reminder, DURP assesses the methodological quality of included studies that have been published in peer-reviewed journals using standardized assessments of risk of bias, which result in ratings of low, moderate, or high risk of bias. And you can see those definitions listed on this slide. In the bottom of the slide, that asterisk indicates that those adjustments for risk of bias were made on those studies that we moved forward from the prior reports. And then slide 15. As mentioned, we used that grade approach to assess the quality of the body of evidence for our outcomes of interest, and we selected those 5 at the top of the slide to be rated. So the body of evidence, which is that group of studies that look at a particular outcome, it's assessed based on the consistency of the findings across the study, the precision of the effects, any study limitations, which is essentially captured as the risk of bias in the studies, and the directness or generalizability of that evidence. These assessments are then summarized as a rating of high, moderate, low, or very low quality of evidence, with bodies of RCT evidence starting at a high rating by default, and then can be downgraded 1 or more levels for any concerns in those domains that I just mentioned. And these ratings correspond with the level of confidence that raters have in how closely an estimate represents the true effect of an intervention for an outcome. And each level is explained here on this slide. So thank you all for your attention, and I'm going to stop here and let Shannon continue.
Thanks, Andrea. Hopefully you can all hear me okay. I was having some trouble with my mic. So I'll move into the findings section. If we can go to the next slide, please. So this presentation, as well as the report, is an alphabet soup. There are a lot of abbreviations, and these ones are those that appear in this presentation. There's a full list of abbreviations in the report, but you should be familiar with most of these as they refer to abbreviations for the drug names, as well as some of the common tools used for diagnosis and response to treatment. If we can go to slide 18, please. So as Andrea said, we did a systematic review, and that meant we searched in bibliographic databases, as well as pulling forward the head-to-head trials from the previous reports. So you can see we started out with around 2,000 results from the databases and pulled forward 78 studies from those previous reports. Once we filtered through everything, doing our screening for the title, abstract, and full text, you can see at the very bottom there that we ended up with 70 studies across 96 publications. 26 of these studies are new to this review, and 44 were brought forward. Next slide. So this is just a quick overview of the findings of how the publications broke down. So I'll just orient you to this table. You can see down the left-hand column are the comparators. So for example, stimulant versus stimulant or stimulant versus non-stimulant, followed by the number of trials for that category, the study size range, the total number of participants, and the range of study durations. So you can see for the stimulant versus stimulant category, there were 34 trials with a total of just under 4,000 participants. And the for stimulant versus non-stimulant, however, there were fewer trials, 20 trials compared to the 34, but there were about 500, 600 more individuals in those trials. And just for this slide, I have combined the newer drug treatments. So those are the stimulant and non-stimulant treatments versus placebo, just for brevity's sake here. If we can go to the next slide. So again, the 70 studies, 26 of them are new since 2015. A majority of the studies did include US participants. The risk of bias for about a fifth of these studies was moderate, with the remainder having a high risk of bias. So 56 of the 70 studies had a high risk of bias. This was commonly due to industry funding, including extensive involvement in the trial by pharmaceutical company staff, as well as some methodological issues. For example, they may have had a short duration of only 1 or 2 weeks, or if it was a crossover trial, they had no washout periods between crossovers. The majority of participants across all trials tended to be male children identified as white who had the combined presentation of ADHD. Slide 21, please. So there are actually 13 new treatments since 2015, but only 4 of those treatments were reported in the new evidence. 12 of these are stimulants and 1 is a non-stimulant. For the 4 newer treatments, there may be more that were actually studied, but most studies did not state the brand name of a drug, so it was difficult to determine if any of the newer drugs were also included in these newer publications. So MyDeus, which is an extended release methamphetamine salt, was compared to immediate release methamphetamine salt in children and in adults and adolescents in 2 small studies. And in the adolescent study, they found MyDeus worked better than the immediate release, but in adults, there was no difference between the 2. And then the remaining 3 new drugs that were included here were Adhansia and Journey, which are both stimulant medications, and Qelbree, which is that non-stimulant, but these were only compared to placebo. So the overall results, we did find that ADHD symptom reduction occurred regardless of the active treatment received and regardless of other personal characteristics such as age, gender, and any other comorbidities. The MCIDs for this are not actually well defined. There are some studies that have linked 2 diagnostic tools, the ADHD-RS and the CGI, the Clinical Global Impression Scale. That was described in a 2010 study. So this is where some of these trials have got their MCIDs, but the trial investigators have then set the threshold for improvement from baseline. So this usually ranged between 20 to 50% improvement from baseline to determine if it was a MCID. In terms of the head-to-head trials, so this could be a stimulant versus another stimulant or a stimulant versus non-stimulant. There was no treatment that proved to be better in general. There was 1 treatment, the non-stimulant atomoxetine, when it was compared to several stimulants was found to be inferior. performance and quality of life outcomes were rarely reported. And as you're probably aware, adverse events are very common with these types of treatments. So a majority of participants did experience at least one adverse event, but serious adverse events and discontinuations due to adverse events were rare. Move on to the next slide, please. So this is the certainty of evidence, or the grade table. Here it's just a summary here. And let me orient you to this slide. So again, down the left column there, you can see the comparators, stimulant versus stimulant, for example, as well as the total number of trials in that category. And then across the columns, you can see symptom response, performance, et cetera. So these were the 5 outcomes that we assessed for certainty. And it also includes in each of those boxes the number of trials that met that qualification of having at least 8 weeks of treatment with that particular outcome. So you can compare across the 5 outcomes in a particular category. So across stimulant versus stimulant, you can compare the symptom response, quality of life, and discontinuations, et cetera. Or you can compare down the column between comparators. So you can compare the stimulant versus stimulant symptom response to that of the stimulant versus non-stimulant symptom response. You'll also note an absence of green dots, so no outcomes had a high certainty of evidence. And these will be repeated in the main part of the finding sections. So we can go to the next slide, please. So these are the new FDA approved treatments. You can see that the bulk of them are stimulant treatments, and the Qelbree that sat there all by its lonesome in the bottom of the second column is the only new non-stimulant since early 2015. So if we can move into the next slide, and we can jump one more. So we're going to start out with actually the placebo-controlled trials, and first up are the stimulant versus placebo trials, and we had identified 6 of these trials across 9 publications, and you can see again across the top of this slide, it gives you the study size range as well as the total number of participants and the study duration. So you'll see that all of these studies had a 1 to 4 week duration, therefore none of them qualified to be assessed with grade. All of these trials were conducted in the US, and there were 2 drugs here, the Adhansia and Journey. So these are 2 of the 12 new stimulant drugs. There are 4 RCTs for Adhansia. Adhansia is a multi-layer release methylphenidate. 1 of these was in children only, and 3 were in adults. And while these adult studies often included individuals up to the age of 50 or 60, you can see that the mean age there for these adult trials was around 36 years old, so it's still skewed towards the younger end of the range. For Journey PM, which is a delayed release and extended release methylphenidate, there were 2 trials. Both of these were also conducted in children only, and you can see that the mean age was 8 years old. All 6 of these trials had a high risk of bias. So if we can move to the next slide, please. So let me just take another moment to orient you to the slide, because you'll be seeing this similar layout throughout the rest of the presentation here. So again, down the left column, we have the comparators. So we have, in this case, the multi-layer release methylphenidate versus placebo, followed by the age range of that trial, the number of trials, the total number of participants, and then any symptom response, in this case, scales that were, or tools that were used to determine symptom response. When items are in bold, so the MLR-MPH is in bold because that performed better than placebo, and then in the far right column where the diagnostic tools are, you can see the bolded text there occurs when there have been statistically significant results. So as you can see, overall, active treatments were performed better than placebo. across a number of different diagnostic tools to determine symptom response. Next slide, please. So in terms of any performance outcomes, there were four of the trials did report the performance outcomes, and they all used the same tool, the PERMP. And again, those active treatments performed better than the placebo when they measured performance. So it was either workplace or classroom performance that was evaluated in a simulated environment over a single day. They may have conducted more than one session and averaged the results from these trials. If we move to the next slide, please. In terms of quality of life, you can see that there were 3 trials here. The first row there, the MLR-MPH, was the adults. There were 2 of those trials, and in terms of quality of life, they measured sleep quality in these adults and found no difference. However, in the study in children of the delayed release, extended release, this is Journey PM, in children, they did find that caregiver strain was reduced in those children who received the active treatment. Next slide, please. So in terms of any adverse events and those related outcomes, the serious adverse events and discontinuations due to AEs, we'll start with adhansia, that multi-layer release methylphenidate. So adverse events were more common in those participants who received the active treatment versus placebo. You can see the bullet points there demonstrate that about a quarter of the children who received the active treatment had at least one adverse event, as well as half of the adults. The studies didn't always include details of what these adverse events were, but where they did, we have included those details. So for example, you can see here in the adults that headache, insomnia, dry mouth, decreased appetite, and nausea were the most common of the adverse events experienced. Serious adverse events were rare. There's only one in an adult receiving adhansia. Again, details were not provided by the report or by the study authors. Discontinuations due to adverse events were also rare. As you can see, there were 8 in the adults, but again, no details were reported. Move on to the next slide. So this is the stimulant journey, which was compared to placebo in children. Again, you can see that a number of adverse events occurred, but they were also highly common in the placebo group, which is interesting. And those common adverse events included headache, insomnia, and decreased appetite. Neither serious adverse events or discontinuations due to adverse events were reported for these 2 trials. Next slide, please. So we'll move on to one more slide, slide 32. So now these are the non-stimulant compared with placebo trials. So these are the new non-stimulant, or the new non-stimulant Qelbree, viloxazine, compared with placebo. There are 5 RCTs that we identified with a total of about 1,600 participants. Treatment periods ranged from 6 to 8 weeks. So a majority of these studies did qualify for grade assessment. Again, all of these studies were in the US and all compared Qelbree to placebo. 3 of those trials were in children where doses ranged from 100 to 400 milligrams per day. And I just want to note here that I'm calling out specifically the race and ethnic groups of the African Americans compared with white children, because it's been generally pretty uncommon for trials to enroll large numbers of non-white participants. So this is where we're beginning to see a little bit more parity, where they are enrolling larger numbers of non-white participants. So similarly, in the 2 trials for the adolescents, there were doses of Qelbree of 200 to 600 milligrams per day. And again, you can see that this trial also enrolled a large portion of African-American adolescents. All 5 of these RCTs had a high risk of bias. Slide 33. So this is the certainty of evidence. There's a little bit more detail here than on the overview slide at the beginning of the findings section. So you can see the 5 outcomes of interest here, and the tabs, so to speak, are color coded. So for symptom response, there was a low certainty of evidence that 2 of the RCTs out of 5 qualified for this review of this particular outcome assessment. And if you look at down the rest of these, you can see there were no eligible studies for performance. And then for quality of life, discontinuations due to AEs and serious AEs, these all had a very low certainty of evidence. There are more details, of course, in the report giving information on why things were downgraded to where they are. Next slide, please. So again, we're going to start with these non-stimulant, this Qelbree versus placebo, and we're going to start with those trials that were in children. You can see that the comparators range from 100 to 400 milligrams, and that all of those performed better than placebo. You can see on the far right column where we start looking at the symptom response, everything's not bold here. So for example, for Viloxine at 100 milligrams, you see the mixed for clinician rated outcomes. This means that the clinicians use multiple instruments. So for example, they may have used the CGI and ADHD-RS instrument and found statistical significance in one instrument, but not in the other. So that means the results were mixed. You can see there that for parent rated symptom response, there was statistical significance. And you can see that throughout, again, that the active treatment tended to have improved response compared to placebo. Next slide, please. So similarly, in the adolescents, where doses range from 200 to 600 milligrams, you can see for both the 200 and 400 milligram doses, the clinician rated symptom response showed significance, but not for the parent rated symptom response. And then for the 600 milligram dose, there's actually no difference when compared with placebo. Next slide, please. In terms of quality of life, all of these studies measured parental stress. And you can see that for the most part, none of these trials found any difference in parental stress when comparing the active treatments to placebo, with the exception of that 400 milligram dose, where you can see there was one trial in children that had some reduction in parental stress. Next slide, please. So for the adverse events and those related outcomes, again, adverse events are common. So most participants experienced at least one adverse event. You can see that about half of the participants who received the active treatments had an adverse event, but you'll also notice that for the placebo groups, they also reported high rates of adverse events. You'll see these common adverse events are loss of appetite, sleep disturbance, drowsiness, etc. For the serious adverse events, they were, again, very rare, with only 7 reported in children and 2 in adolescents, as were the discontinuations due to adverse events, with a total of 45 reported across these trials. Neither the serious adverse events or the discontinuations due to adverse events were reported. The details were not reported. Move to the next slide, please. So we're going to get into the head-to-head RCTs now. So if we can move on to slide 39. So as a brief overview, we're going to start with the stimulant versus stimulant RCTs. So there were 34 across 45 publications with just under 4,000 participants and study durations of 1 to 16 weeks. 7 of these studies are new. to this report, the remaining studies were brought forward from the previous report and spanned from 1975 to 2014. 14 of the trials are traditional RCTs, but the majority of them were crossover RCTs with very short treatment phases and generally no washout periods between. They did tend to wash out before the beginning of the trial, but when they did those crossovers, they immediately started the next treatment rather than having any washout between those treatments. So a majority of these RCTs were in children and adolescents. So you can see there that even when they enrolled adolescents, the mean ages still skewed towards the lower end of the range. There were 4 studies that enrolled adolescents only. And then there were 3 studies that enrolled adults. Again, you can see that the mean age skews towards the lower end of the scale when they enrolled adults up to the age of 60. About 3/4 of these trials were conducted in US populations or included US populations. And most of these trials had a high risk of bias. Again, this tends to be due to industry involvement, as well as methodological issues such as those short treatment periods and lack of washout or blinding. The remaining 4 did have a moderate risk of bias, and this was due to industry involvement. Next slide, please. So of these 34 RCTs, there were only 3 that qualified for a grade assessment. So you can see those results here. Again, the red indicates a very low certainty of evidence, and the orange for the serious AEs on this slide are for is a low certainty of evidence. Next slide, please. So from here on out, we're going to focus on only the new studies. So I have highlighted those in a green box that you should be able to see on this slide. So we'll start here with these new trials published in 2015, and you can see the number of trials here. There's a total of 4. Again, you can see that there were very mixed results. So for example, the immediate release mass versus an extended release mass in adolescents, the extended release mass did prove to reduce symptoms more than the immediate release, but the actual scales that were used, there was some mix between the clinicians and the individuals when they self-rated their symptom response. You can also see that in the adult trial of immediate release versus extended release, that there was no difference in symptom response. And for Lisdex versus an oral, another type of oral, can't say that word today, oral release methylphenidate, there was Lisdex performed better, but there was again that mixed result of symptom response. And lastly, the last group of RCTs there are in children and adolescents comparing methylphenidate, a form of methylphenidate, to either another form of methylphenidate or Lisdex, and found no difference. Move to the next slide. So these are studies from the previous report, so they were published prior to 2015. They're here to for completeness so that you can compare the findings of those new studies and these older studies in this presentation. Briefly, you'll see that the older studies have similar outcomes, or sorry, similar outcomes compared with the newer studies, and the newer studies haven't actually moved the needle in terms of efficacy of these treatments. Next slide, please. So in terms of performance, on this slide, you can see there are 4 rows. 3 of these are newer trials. So there were 3 small studies with under 100 participants each that measured performance. You can see that in the children and adolescents, so that's the first and third line, they used a academic performance scale and found some statistical significance for the extended release methamphetamine salt or the oral release methylphenidate. But for the adults, there was no difference in workplace performance. And as a reminder, these were in simulated environments over either a single day or multiple days where they averaged the outcome. Next slide, please. So for quality of life, there's a single new study that measured the parental stress and did find that for the children who received the Oros MPH, the parental stress was reduced compared to those who had children on the immediate release MPH. Medication adherence has actually been frequently reported across all trials. So here we have two RCTs that compared immediate release methamphetamine salt to an extended release and had higher adherence in the both adults and children for the immediate release versions of these methamphetamine salts. Next slide, please. So the adverse events, I won't bore you by repeating it, but they're common across these medications, as you're aware. In terms of serious adverse events, they were also rare, with less than 1% of participants experiencing a serious adverse event. So there were only 10 reported across 9 RCTs with just over 1,000 participants. Discontinuations due to adverse events were also rare, with around 3% of participants experience discontinuing the trial due to an adverse event. So the most common were decreased appetite, facial tics, and headache. Most of these did occur in children and adolescents who received the Lisdex or a long-acting methylphenidate. Next slide, please. And we can move one more forward. So these are going to be the stimulant versus non-stimulant head-to-head trials. So we had 20 RCTs across 30 publications. You can see again the study size ranges there, and with about 4,600 participants across these 20 studies. The duration of the studies was 2 to 26 weeks. 8 of these studies are new to this report, and the remainder were previously reported. The majority of these trials were traditional RCTs. There were only 4 that were crossover RCTs with short treatment phases of 2 to 6 weeks. So as we saw in the stimulant versus stimulant group, even when the studies enrolled, we've jumped out of the slides, it looks like. Should be on slide
This is
47.
Lita, sorry about that.
That's okay.
My computer just froze. Ay, ay, ay. Just a minute.
It's one of those days. The sun's coming out here, so that's something. So we should be on slide 47.
There we go. It wants to come back.
Oh.
It's there, it just, okay. Hang on.
I'll take this opportunity to have a sip of water.
There you go. It's open, it just won't stay on my screen. Hang on.
Oh yeah, it looks like PowerPoint is having a meltdown. Everybody take a moment to stretch.
Yes. Okay.
One of my cats is wanting to join in the fun. So.
it won't let me move.
Are you able to give me control?
Oh, wait, it came back. Hang on just a second.
Oh.
Okay. We're on 44. Is that correct?
47.
47.
Perfect. Okay, fingers crossed. We can get through this, you guys. Okay, so I'll just kind of back up. So we had 20 head-to-head trials here for the stimulant versus non-stimulant category with about 4.6 thousand participants. 16 of these trials were traditional RCTs with 4 that were crossover RCTs. In terms of age group, you can see that the majority of them enrolled children or children and adolescents, though even those that enrolled adolescents still had a low mean age of 10.7 years. And 2 enrolled adults. Again, the mean age was towards the lower end of the scale, though one of them did include a mean age of 41 years. Just over half of the trials included some US participants. And again, about half of the trials had a high risk of bias due to industry and methodological concerns, and 8 had a moderate risk of bias. Next slide, please. So on slide 48 here, we can see the certainty of evidence. And there were 13 of the 20 had at least 8 weeks of treatment and qualified for at least one of the outcomes assessed here. So you can see that for symptom response, there was a moderate certainty of evidence. This is the highest level of certainty of evidence we had in this report. And then for the performance and discontinuations, these are both low, or very low, and for serious adverse events, this was a low certainty of evidence. Slide 49, please. So again, we'll focus on these newer studies, so those in the green box. Generally, there is no difference found. You can see in that first row, this was the majority of those trials, 8 of them with 1.1 thousand participants aged from 6 to 50. And this compared dexmethylphenidate to various non-stimulants, including a combination of a non-stimulant given with a stimulant. For in this trial, it was a 4-arm trial, the second row here in ages 7 to 14. The participants who received the combination of a non-stimulant, guanfacine, and the dexmethylphenidate, dexmethylphenidate, they did have better symptom response compared to those who received the non-stimulant on its own. And the bottom 3 rows are again the older trials here for convenience. Next slide, please. So in terms of performance, you can see there was just one small trial that qualified for this, and this was a workplace performance in adults, and no difference was found in terms of those performance ratings. Next slide, please. In terms of quality of life, there was one trial of just 50 participants. These are all children and young adolescents, so ages 6 to 14. And they measured sleep in a subgroup of these children and found that sleep had improved in those who received the non-stimulant atomoxetine. In terms of medication adherence, this was reported only by 2 trials. You can see that in the first trial on that first bullet there, the immediate release methylphenidate compared to atomoxetine in drug-naive adults, there was no difference in medication adherence, but in the second bullet point there, the stimulant had better medication adherence in drug-naive children than it did in the those that received the non-stimulant. Next slide, please. So again, adverse events, very common, and the types of adverse events are as expected, loss of appetite, daytime drowsiness, headaches, etc. Children who received the combination of methylphenidate and clonidine, which is an antidepressant, were more likely to experience an adverse event than if either drug was given on its own. And serious adverse events were, again, rare, with less than 1% of participants experiencing an adverse event. And you can see that the majority of those serious adverse events occurred in those who received a stimulant. Slide 53. In terms of discontinuations due to adverse events, again, these were actually relatively rare. It looks like a large number there of 179 in 16 RCTs, but this is about 5% overall. And the majority of them occurred in the non-stimulants. Actually, is kind of similar, but slightly more in the non-stimulant atomoxetine. In terms of why participants discontinued due to adverse events, it really varied by the drug. So here you can see the 3 drugs here, atomoxetine, Lisdex, and MPH, and the different reasons why. The most common reasons that were given for discontinuation due to an adverse event. So things like abdominal pain, chest pain, nausea, and rash for atomoxetine, agitation and tics for Lisdex, and decreased appetite, mania, etc. for methylphenidate. Move on to the next slide, and actually you can go one more to slide 55. These are the stimulant versus off-label treatments. There were no new studies identified here, so we'll go through this a little bit quicker. There were 4 RCTs that were brought forward from the previous reports that compared a stimulant to an off-label treatment of either bupropion or modafinil. And you can see the 2 of each. There were 2 studies under each of these 2 off-label treatments, and you can see that there were 3 of these studies were high risk of bias and 1 was a moderate risk of bias. Next slide, please. So again, these are the older studies, so I won't spend any time here, but you can see that the stimulant compared to an off-label treatment, there was no difference. But these were all very small trials. Next slide. And again, adverse events were common, particularly in those who received the stimulants, and they differed by age group for the bupropion. So drowsiness, fatigue, nausea, anorexia, and dizziness experienced by children, whereas adults were more commonly experiencing dry mouth, headache, and insomnia. And discontinuations due to AEs were rare. For modafinil versus the stimulants, again, the AEs were more common in the 2 stimulant medications compared with the off-label one, modafinil in this case, and the reasons were, the types of adverse events were different for the children and adults. Next slide, please. So this is the last section of the head-to-head studies, and then we'll move into the ongoing studies. So if we can move forward one slide. So this is, there was only 1 study identified that was a non-stimulant compared to a non-stimulant. The original study was actually published in 2014, but there was a post hoc analysis published in 2016. So those are the results that I'll discuss here. Again, please note that the age range of 6 to 17 years, but the mean age was 10.8, so skewing towards that lower end of the scale. And in this trial in particular, they had allowed a high proportion of individuals with a comorbid diagnosis, in this case, oppositional defiant disorder, and that was a rarity among these trials. The risk of bias for this study was moderate. Next slide, please. So for the certainty of evidence, we only had the 1 trial, and you can see that for symptom response discontinuations due to AEs and serious AEs, these are all considered to have a low certainty of evidence. Next slide, please. So this is that first line at the top that's outside of the green box. Those are the results from the trial that was originally published in 2014. So you can see guanfacine performed better than atomoxetine at that time. And this post hoc analysis stratified participants by whether they had had prior MPH use or if they were MPH naive, and determined their symptom response. They did only compare that symptom response to placebo. So you can see that for those who had prior MPH use, there was no difference between atomoxetine and placebo, but there was for guanfacine compared to placebo, with guanfacine performing better than placebo. And for those who were MPH naive, either of the active treatments showed an improvement in symptoms compared to those who received placebo. Next slide, please. Again, adverse events super common in these treatments. The type of adverse events that were unfortunately not reported in this trial, but you can see that large portions of individuals who received the active treatments did have at least one adverse event. The SAEs were rare, and as were the discontinuations due to AEs. Next slide, please. So we're going to look at the ongoing studies here. If we can go to slide 64. Thank you. So the first three lines here are head-to-head trials, so they're above the solid green line. So the first row here is a stimulant compared with another